Okay, let's, let's start with communication with colleague. Communication with colleague is the simplest domain to pass. Reason being, there are very few points which you have to remember. But when there is something very less important, it's very easy to forget that, right? If you have decided that, okay, you are going to go tomorrow and you have to buy a car, and you have decided that tomorrow you are going to clean your cupboard. Probably you will forget to clean your cupboard, but you will definitely go and buy a car because that was the bigger agenda. Right, Saroja? So
Yes,
what
yes.
happens, including your colleagues, are so very simple that you tend to forget that. And unfortunately, communication with colleague is otherwise the simplest domain to gain the marks or to clear the domain. How would you remember that? Always, whenever you start your second part of the task, girls, listen to me very carefully. Whenever I talk about tasks, I always divide in two parts. First part, where there is information gathering, and second part, and examination. And second part, we start with normally with BBN, explanation of diagnosis, implication of diagnosis. Again, Saroja, I repeat, second part
Yes,
of the
yes,
class,
ma'am.
you start with BBN. Mostly tasks are going to include BBN. So first it's BBN, then diagnosis explanation, then complication of explanation, diagnosis. Always remember that when you are giving any kind of fear to patient, what is next thing which you are going to do? Next thing you are going to do is you are going to give confidence to patient that I am there to help you. So BBN, diagnosis explanation, complication of that particular diagnosis or condition. Immediately after that, Saroja, include MDT.
Okay.
Okay, so I'm sorry to say that you have this condition. It is like life-threatening, this and that. You have heard about this PPCM. Okay, this is the diagnosis. This heart weaker, not able to pump. This. Now the complication that there is a risk of heart failure, even death, and there is a chances of worsening after, like in some condition. If you plan pregnancy, there is again a risk of having it again, etc., etc. You have to be on the medication regular, this and that. It is to have some implication on baby as well. There would be a risk of not growing properly, delivery before time if you plan pregnancy next time. Now patient is so much afraid that, okay, I may die. Even in next pregnancy, I'm going to have a same experience. So what you are going to do? Immediately you are going to offer MDT. And whenever you say MDT, Saroja, it doesn't mean that you will start from A to Z everyone. You have to make sure that you will involve only relevant MDT. If you fail communication with colleague, everybody listen to this very carefully. If you do not clear communication with colleague, it means there are two reasons. First, probably you have not included the required one, or probably you have included more than not required one. In both the cases, you will not clear communication with colleague. Saroja, you have to
Yes,
make
yes,
sure,
ma'am.
is there something that you have included even someone who was not required in that MDT team or in that multidisciplinary team or expert team? That could be one of the reason of not clearing exam. So everyone who is not able to clear this particular domain, try to rewind your exam and your station scenario, that whether you have included everyone or whether you have included someone extra, that is also going to deduct your marks, because this is going to give an impression that you are not aware of the condition, so you do not know what all expert doctors you need to be addressed. Clear, Saroja?
Yes, yes, ma'am.
So this is how it is. So first thing in communication, colleague, immediately after BBN diagnosis complication, include MDT. If you make this way your format, that this is going to be your format. So in every task, automatically you will present your second part of the task this way, and there is no reason that you will forget including MDT. But again, you have to make sure that whether you are including the required one or you are just saying the name of doctors or GP for the sake of saying. This is very important. And the last, whenever you finish your task, whenever you finish your task, three, 4 points you have to always keep in your mind. First, referring back to GP or midwife, providing the written information. Never say information leaflet, because we do not have information leaflet from RCOG for every condition. So sometime you go for NHS, sometime you go for Medscape, sometime you go for PubMed. So always say written information, support group, and
பண்றதுன்னா
arranging
ஓகே, பண்றதுன்னா
appointment with arranging an appointment with
நான் சொல்றேன். இப்ப அதுங்க ஓவரா பிரச்சனை பண்ணுதுங்க,
Saroja.
அதனால நான்
Please
சொல்றேன்.
mute yourself. Okay. So where was I was okay. Last 4 points. Once you finish your second part of the task, that referring back to GP or midwife, providing written information, putting in touch with support group, arranging a meeting with consultant. If you remember these 4 points and always include in all your tasks, Saroja, you are not going to miss your exam, or you are not going to lose communication with colleague. Because when we talk about communication with colleague, it's about MDT, it's about referring back to GP or midwife. And third, very important point, during information gathering also there are certain point when you talk about your colleague. If a patient is complaining of any kind of emotional distress, depression, feeling low, immediately you have to offer counselor. That is also included in MDT or communication with colleague. If somebody is having any psychosexual problem, immediately you have to offer then and there that, oh, I'm not able to have intercourse, or my husband is facing this problem, so it is creating problem between this and that. So it means patient is facing problem because of the some sexual condition, so you are going to offer psychosexual counselor then and there in information gathering. So these are the certain points, Saroja, if you take care of, you are going to definitely clear communication with colleague. And trust me on that, amongst 5 domains, this is the easiest one. Am I clear, Saroja? Okay, so now moving further, we'll just quickly, I'll just give you idea because most of you are aware of this, but still. Uh, so I'm Dr. Pooja Arora Bhatnagar, your mentor, your buddy, your friend, and I'll try my best to help you in clearing the exam part 3, and that is in May 24. Earlier they were conducting 3 times, but now they are not conducting it 3 times. It's only for 2 times, that is in Jan and in November, and it's now going to be only offline. There is no reason that it is going to be online anymore, unless we have another COVID or something like that, which I wish we should not have ever again in our lives. So when we talk about part 3, it is not separated from part 1 and part 2. Part 3, part 1, whatever you have read in part 1, if you have noticed that in part 2, that was in more elaborated form, that was more detailed. Whatever you have learned or whatever you have exam given or task test given in part 1, you got all the details in part 2 of all those questions. If you remember ureteric injury, if you remember certain, like I would say that all syndromes, and that azoospermia, if you remember that question of azoospermia, that if it is diabetes, what would be FSH, LH, this is, there were 3 4 options, then you have to take. Once you go through the part 2, then it becomes so easy to understand part 1, because in part 1, frankly speaking, we were just just reading and remembering. We were not going through the details, which details we have gone through in part 2. And part 3 is whatever you have learned in part 1 and part 2, you have to speak. So basically, part 3 is not about reading. Part 3 is not about listening. Part 3 is only about speaking. So it is very, very important that you stop listening to other candidate. You stop reading to guidelines only and reading to template and reading chaotic library. It is my humble suggestion to all of you. Please avoid any kind of chaotic library. It is a trend now that in the name of library, so many stuff like, okay, you read 4-line template, then easy read, then this and that. That takes your time, that takes your confidence away, because whenever you open your library and you see, oh my God, for one task you have to read almost 10 hours of this chaotic library. So I'm definitely not in favor of that chaotic library. It is only RCOG, nice talk and information leaflet or written information which you need to go through. That's it. Just try to understand that all the mentors who have cleared exam 3 years back, 4 years back, and the new tasks are coming, and they are also making template. So where are they making template from? They are making template from this GTG, nice talk, and from that information leaflet and written information. Also, one of you may be a mentor later on after a year or so. There is a possibility one of you may start your own course. So if you are so much afraid of making template and one of you are eventually going to be mentor later on, so how will you do that? I was also a student once upon a time. No, I am also making new template whenever a new task is coming. So it means that it is not an impossible job. It is something which is very much doable. So please come out of that fear. That is very, very important. I have seen that you all of you have so much of fear of part 3. It is more than part 2, though the part 2 is the difficult one amongst all three. I don't know why you all have this much fear for part 3. Probably in part 2 you are on your own. You are not interacting with someone. You and your paper is there, and so you have that confidence. Nobody is watching you, nobody is listening you. Even if you rub a question, rub your answer, you can make it again. So that could be one of the reason, right? Because Ruma is writing so much of fear. I'll take all your fear away. That is for sure. That is for sure. This I can guarantee you, Ruma. After this session, there won't be any fear, right? So, but in part 3, the fear is that somebody is listening to you. You are presenting in front of someone. That is the fear which is overpowering all your capabilities, because you have that fear somebody is listening to. Then and there you have no chance to rewind that, revert that, or just remove that answer and make it again or write it again. So that is the fear which you are going through. You all are postgraduate. I'm sure all of you have given viva practical exam. So why this fear? This is, see, somebody who is giving MRCOG after MBBS, I understand, but I do not understand all the postgraduate in obs and gynae practicing, why you all have this fear. This is my humble request that please come out of that fear. And you all are capable enough. You all do this on daily basis in your clinic, counseling all your patient for unknown situation condition. If somebody is entering in your chamber in your clinic, you really don't know what conditions he has come for, but moment you see her reports, moment you see take her history, you are able to address that. So why can't you do that in exam? An exam when you are already aware of all those 180 topics, right? Those 180 topics you are already aware of. So please take out that fear. This exam is something that out of the box, something very fearful. This is a very wrong impression given to you. Very wrong impression. This is a very much doable exam. Very much doable exam. I repeat, it is very much doable exam. The only thing you should know how to prepare. So what all you need? Guidelines, that is GTG, NICE, talk, SIP, executive summary. Whenever you see, this is for you, Yogpriya. Can you unmute yourself?
Yes, ma'am. Yes, ma'am.
So
Yes,
this
I'm
is
good.
what you need. Executive summary of this. In GTG, it is clearly given separately, right? First 2-3 pages of GTG is executive summary, which is summary of complete GTG, which is summary which you need to present a task. Beyond that, you do not need to speak. You do not get time to speak.
Yes,
So
that's
if you want to go through GTG, just go through once. After that, take the printout of this executive summary. That is all. We do have certain nice, we do have certain talk. For talk, I would suggest take out the print and then highlight the important lines. Just take a light, your favorite color highlighter, if you like green, if you like orange, if you like pink, and highlight those important points. So whenever you want to revise, you are going to revise those highlighted points. Same with nice, right? Always take printout. This is my personal suggestion, because most of us are from the era where we used to read only from books. This laptop probably is not our cup of tea. So my suggestion would be take printout. This is one time work, one time job. Just take printout of, if it is GTG, if it is nice, if it is this, and information leaflet, take the printout, staple. Make your template, again staple. Keep 2-3 pages extra in that. Whenever you get any other information, whenever you join any free session, whenever you find anything new about that task, that topic, note down in those 3-4 blank paper. I repeat, take printout of executive summary, or if it is nice, or if it is talk, take out those printout. Then information leaflet printout is very very important, staple. Then your written template, whatever template you have made for that particular task, again staple in that. After that, 2-3 plain paper. So whenever you get anything new, rather than making a new template, just note down those important point in that template. And if it is possible, I would suggest to make proper stapled information, whatever I have given for each task. And just write sub-fertility, task 1, DM, azoospermia. And all information should be there in one staple. So whenever you want to revise, you just open that particular folder of sub-fertility, just take out that printout, take out that particular folder of DM, go through that, and how to prepare tasks. Read, revise, record, rectify. Read. Read your template twice. Properly read your template twice. Revise. Revise in your mind twice. Whatever you have read from I am so and so till thank you for your time, revise in your mind with questions. Okay, how can I address you? Okay, revise with a role player in your mind. Twice you revise. First read, then twice you revise, then record. Please do not jump for recording immediately. First, read your template properly from first line to end line. Then revise in your mind twice. Then record once. Listen to your recording and rectify. So it's read, revise on your mind, your template, then record. After recording, listen to it yourself. You will definitely would be able to understand where you are lacking, where your empathy is gone, which investigation you have forgotten or whatever. Then rectify all those in your mind and then again record. So it's read, revise, record, rectify. These are the important study material. Now template. This is something very important. Please, I always say, do not complicate your template. Please make it very, very, very simple. Very simple. Divide your information gathering in two parts. Target. Please, everybody mute yourself. It takes away my, concentration. Who is this?
Yes, Hamza. Hamza?
Everybody, please mute yourself because it takes like my flow away. Okay, anyways, make your template as simple as possible. Please do not complicate your template. Like complicating template is not going to show that, oh my god, this doctor is extra intelligent or brilliant. Probably you may give this impression, but there is very much possibility that you won't be able to remember all 120 180 recalls, and you would be you won't be able to give 100% all your tasks, because complicated templates are not going to be easy to remember 180. Please make it very simple. Make a proper format that you are going to follow that format every time. If it is a maternal medicine, or if it is like yeah, okay, let's talk about maternal medicine. Make it very simple. First, what is the diagnosis? Probably she is aware of her diagnosis because she is living with this condition in for past 10 years. Probably she might be having more knowledge than you. So if you talk about her condition, just do the mild BB and okay, you have this condition. Probably this is going to affect your pregnancy this way. This is going to affect your baby this way, and pregnant, and this is going to affect your condition. Pregnancy is going to affect your condition. Pregnancy this way. So this is how you are going to start your second part of the task. So these are the complications with mild BB, and that I'm afraid that it may have this, though some may have a normal or straightforward pregnancy. After that, when you have addressed all the complication, immediately offer her MDT brief. Now you will be under the care of this. Immediately, then antenatal, intrapartum, and the postpartum. Always remember that you are going to follow this way. So first, you will offer that she will be in the consultative unit. There will be frequent visit, but obvious, right? After that, give her all idea about what all investigation start from the booking test till that growth scan. Whatever you are going to offer her, what is in common and what is particular for that condition. Okay, if she has Marfan, so you have to address about echo. Rest, it is going to be same as like starting from dating to Down syndrome to level 2 scan to down this 28 weeks or 26 growth scan GTT if it is relevant. Second part, you will talk about the medication. Start from the folic acid, then ecoswin, then whatever. So first part, all investigation. Second part, all medication which you are going to offer from start till end. Then anything specific about that antenatal care. Then jump to postpartum. When you talk about, sorry, intrapartum. When you talk about intrapartum, first you talk about where she is going to deliver. Second, who is going to take care of it? Is midwife, whether it's you. And third, you will talk about CTG, if it is required or if it is recommended in that condition. In most of the condition which we discuss, because we hardly discuss any low risk pregnancy in any of the tasks, it is 99.9% high risk pregnancy. So it is CTG is there. Sorry, CTG is there. After that, it is going to be, you are going to offer normal delivery and cesarean if it is indicated. Then post delivery, you will talk about that will hand over the baby. Then talking about the breastfeeding, then encouraging for walking, eating, drinking, etc. Then reassessing for the DVT. Then coming back to then this contraception. Then coming today, that today you have come, so you'll start folic acid. If you make a format for all the maternal medicine this way, whatever condition they are going to give you, you are not going to forget. In the end, okay, whatever I've discussed, I'm going to write for the document for the midwife reference, arranging a meeting with my consultant with this test, and putting you in touch with the support gap and return information. These are the last four ending points. Make your template as simple as possible. If you make any template complicated, you are not going to remember it, and the pressure of exam, trust me on that. Algorithm is very important, very important. In the end of every most of the GTG, you will be finding kind of algorithm. If you remember that algorithm, especially in the case of gynae cases, when there is endometrial hyperplasia, when there is postmenopausal cyst, when there is premenopausal cyst, it is really important to remember only algorithm. None of any other part of that GTG is required. It's only algorithm which you have to keep in your mind and which you have to revise as much as possible. That is very important, because that is the only thing which is going to help you. So whenever you are making templates, so you have staple GTG, you have staple information leaflet, you have staple your written template, and you have staple some plain blank paper. Do staple algorithm paper as well. That page is very important. when you are going to revise your all templates just 10 days before exam. Timeline, I always say. And I have noticed that many of the students couldn't clear the exam because once they were finishing their task, then role player said, no, I wanted to understand about that, because you have not given her timeline. You have just started, okay, you have this condition, so in this condition we are going to offer you the, okay, so now I'll offer you lifestyle changes, do this, we have an option of medication, so take this medication, that medication, going further. When you reach your 9 minutes, then you started talking about surgery, then she says, I only wanted to understand about surgery only. Now you don't have that time. Now you don't have that time, and when you can explain her about surgery. Am I wrong? Anybody has faced this problem in exam, that after like almost reaching 8 9 minutes, then role player says, no, I don't want to understand this, I want to understand that. Somebody has faced this? Anyone? I want active participation. It should not be one, like, it has to be two-way road. Anybody notice this thing, that after completing 8 9 minutes, then role player says, oh my god, I don't want to understand this, why you're talking about this, I wanted to understand that particular treatment. Somebody has faced this?
Ma'am, as per my knowledge, the structured discussions are more difficult than SPT, ma'am. Uh, that was the thing, like the lot of patient safety point, all those things. I think I got failed because in SPT the time was there, ma'am. For me, the time was there because I keep on focusing on the patient's questions and I was answering that. But for structured discussion, labor ward prioritization,
We
these
are going
sessions
to
were so
discuss. We
difficult.
are going to discuss level work prioritization after, in the end of this session. That is again, I'm sure after the once you'll go through level work prioritization with me, that won't be a problem for you. That I can again guarantee you. Rest, if you're talking about SD, I'll try to take another free session for SD in next 1 week to 10 days. I'll try my level best for that. Okay.
Okay, ma'am.
Yeah. So always, whenever you start your treatment, so it's BBN, you explain diagnosis, you explain complication of that particular condition, you offered her expert team, then you give her timeline. So Zara, for your condition, we have an option of lifestyle management. There are some medication. We can offer you some surgery as well. Do you have any preference to understand? Let her decide. If she says, no, I don't want to go for surgery, I only want to understand about the medication, in that case, you have to give her all details of the medicine of that drug. That what is the dose, what is the route, what are the side effects, what are the complication, and what are the contraindication. Only then your medical treatment is going to be a complete treatment. You have to mention route, you have to mention dose, you have to mention side effect, you have to mention contraindication. And that is only possible when you know that she wants to understand only about medicine. She doesn't have any interest in surgery. But if you don't have that idea, then definitely you want to finish medicine fast because you want to jump on surgery. But if she says, no, doctor, I don't want to go for medication, I want a definitive treatment, and whether surgery is definitive treatment, yes, Zara, then please explain me about surgery. In that case, surgery first, you will tell the principle of that surgery. Obviously, after mentioning name, you will mention the principle of that surgery. Second, what kind of anesthesia? Third, what kind of incision? Fourth, what is the success or failure rate? Fifth, what is the side effect? Yeah, complication. So how you are going to start? First is the procedure's principle. What is the principle of that particular procedure? What kind of anesthesia? What kind of incision? What are the complications of that surgery? Chances of recurrence? These are the 5, 6 points which you have to cover in surgery. In complication, you are going to talk about two type of complication: general complication, which is associated with all surgeries. We talk about bleeding, we talk about infection, we talk about wound scarring, we talk about blood transfusion, we talk about anesthesia risk. This is general, and then specific, which is pertaining to that particular surgery. So you have to mention both. Always make a rule of giving timeline to the patient that we have these 4, 5 options. Do you have any preference to understand? One of my candidate told me that it was second stage cesarean, or no, it is like patient was in second stage or something, and her GTG was suspicious, and she was explaining about instrumental delivery, like she was talking about vacuum, she was talking about forceps. When there was like almost she finished her 7, 8 minutes, then patient told said, see that I'm not interested in any kind of instrumental delivery, I want to go for cesarean. Now she was having only, I think, 1.5 or 2 minutes, and where she was supposed to explain her second stage cesarean section. I asked her whether you have given her timeline that you have an option of instrumental or assisted delivery and the cesarean. She said no. I said, okay, this is the situation. This is this. Now we have an option of delivering you or expedite your delivery, because it is like something I don't remember exactly what was the situation. So I started with instrumental delivery, and it took good her 2, 3, 4 minutes to complete instrument, like talking about forceps, talking about vacuum. Once she reached for cesarean section, which was her main interest, and talking about second stage of cesarean section needs extra point, extra time. So if she would have given her timeline that, okay, you have these 3, 4 options, do you have any preference? Then you have to always talk about what is her preference first, though you are going to mention the name of other as well. And once you are done with her preference, and if you have time, you will say, would you like to understand other options as well? Do not complicate it, it's useless. This is something which I'll keep repeating throughout my sessions, every time in daily task recording, in my feedback, that do not complicate your template, it is useless. Template always, as I told you, take printout, staple, plain paper. So whenever you get anything extra, rather than making all together a new template, just note down the important point, right? Information gathering, 3 points. Right, communication colleague, 2 points. So whenever you're talking about communication with colleague, those extra point which you have written in plain paper, you will add. So anything you can add. Very first day, start making template. That is very, again, very important. If you think that, okay, today I'll read GTG and the written information, and I'll make template in my mind, and after some time I'll make this template, I'll write this template, today I'm not in mood, this is going to waste your time. Please control your mood and be more active and be more precise, that from very first day you have to make a simple but a perfect template. From the very first day, do not leave anything for tomorrow. Tomorrow never dies, tomorrow never comes. So if you are reading any even single task you are reading today, you are, please take printout and please make a proper simple template. That is very important, because once you make template, revision is a child play. It will not take even 3, 4 minutes. If you have a proper written template, it will not take more than 4, 5 minutes. Trust me on that. And that will take all your stress away, because whenever you want to repeat, whenever you want to revise, it is so easy when you have a proper template. So it's my request that if you start writing down the things, that would be difficult for the first time only. After that, it is going to be very easy, very only one time. This is one time difficulty when you are making template for sexual assault. But once you made and once you taken all the print out, whenever you are revising, it will like a butter for you. It will be so very easy for you, and you will be so relieved that you have made it. Okay. Now domains. Now we'll talk about domains and what all important points you need to include in that domain, right? So this is something which is going to help you in passing that domain. So girls, whoever find a difficult patient safety clearing, no, nothing is like sounding stupid, Manoj. Manoj, are you preparing for the first time? Manoj?
Yes, yes, ma'am.
Okay, so
Yes,
never,
actually.
so it's again, it's my request. Please do not degrade yourself. Please do not degrade yourself by saying that, that a stupid question. These free, sessions is for that purpose only, that you can ask all the question which is in your mind. Okay, so how to make a template? Okay, I'll definitely guide you for about that now itself. First thing, whenever you make template, write say sub fertility, make a folder, buy a folder, just mention there, put a slip, sub-fertility, right? Then take 3 4 print out of that particular guideline, then take print out of that information leaflet, then start writing your template. The very first thing, I am so and so. The very first template you write properly. I am Dr. Manoj, one of the doctor posted in sub-fertility clinic today. May I confirm your name and age, please? Me, how can I call you? Okay, so I have gone through your case notes. Please tell me how can I help you? Or I have gone through your case note and I understand these concerns you have. Whatever language you want to write, this is your choice, right? Then, okay, I'll address all your concern in a while. Before that, may I ask you a question quickly to know more about you? Yes. Then information gathering comes. In information gathering, you have to divide information gathering in two parts, that is HOPI and the routine one. In HOPR, you are going to ask the relevant question. If it is question about, say, hyperemesis gravidarum, then you are going to ask about that. First, can you give me details of your condition? How many times you are vomiting? Or rather than vomiting, you will say throwing up, because in SPT, you have to use layman language. Okay, whether it is food you are throwing out or something else, or have you started any medication, any particular time you are noticing it, something this you are feeling low, what is about your, how is your like peeing about, whether you is there any decrease in the frequency of peeing. This is going to about your hyperemesis gravidum. Then you're talking about pregnancy. In pregnancy, because it is early pregnancy, can you tell me more about a pregnancy? Have you started folic acid, any other problem or any other complication like pain in tummy, bleeding from down below, etc., etc. Then any booking test this done, or any blood test being done, any scan being done. So this is how you are going to write properly. You have to write properly. It will take almost 2 hours when you write a template. Then you will go for the routine template. Routine is then her gynae history, then her other obstetric history, then her medical history, surgical history, family history, occupational history, family support history, then her mental history. Then you will talk about her BMI, blood group, any Jehovah Witness, then you will confirm that as well. Then smoking, alcohol, drugs, anything else which you can I can do for you. This is how you are going to write your information gathering. Now her examination, that general well-being examination, then any particular examination, if she's 24 28 weeks pregnancy, then second part of the task you are going to start. First, you'll start with the mild BBN, because this is hyperemesis gravidarum. It is going to be mild BBN because it is going to affect, at times it may need admission as well. So it is going to be a BBN for sure. That I have certain information which I have to share. Can I go ahead? You want to someone be with you? You write these lines properly. Then what is the condition? You will explain the hyperemesis gravidarum in 1 or 2 or 3 lines. Because of the certain hormone which increases in pregnancy can cause this condition where patient is throwing up, and it can cause decreased urine output, and sometimes patient may need admission. This is what we call as a hyperemesis gravidarum. Then after that, you are going to offer MDT. So you'll be under the cure expert team of this. Then you are going to write it everything. Then we have option of this treatment, first line, second line, third line, injection, admission, warning signs, everything you are going to write. Manoj, are you like did you get it?
Yes, ma'am. Very nicely explained.
Yeah.
Thank you.
So after that you write it properly, that In the end, you are going to write that GP reference, then support group, then written information, arranging a meeting with my consultant, goodbye, tata, take care, that's it. And this is the way you are going to write all your template. It is going to take lots of time when you are going to write your first time template. Second time you will take little lesser time. Third template much lesser. Then eventually by reaching 10th or 11th template, you will be an expert in writing template. And once all your 180 recalls are ready, you just imagine your 180 templates are ready from introduction till bye bye. And whenever you need to revise it, is it going to take more than 2-3 minutes?
Yeah. Yes, ma'am.
No? Okay. So now everyone, patient safety. Everyone, patient safety, what all you have to remember when you say patient safety. Okay. In patient safety, if somebody who is not able to clear patient safety, please remember all these points. Confirming patient's name, confirming patient age, confirming patient's NHS number. This is in the beginning, and this is while talking about report. So you have to confirm name and age in the beginning. You have to confirm name, age, NHS number on report. You have to rule out if there is any drug allergy or any other allergy for that matter, any medical or surgical comorbidities, any, you have to confirm whether she is Jehovah Witness, addressing her concern. This is very important, patient safety. She wants to understand certain point, and you have, she have a particular task has A to D 4 points. She wants to understand C points, and you have spoken lot about A, B, and D. It is not going to help you because she wants to understand about C. So addressing her concern is very important when we talk about patient safety. Correct evidence-based management. Correct evidence-based management, that's very important, patient safety. Talking about blood group GRS typing, that is again patient safety. Contraindication as per health condition, that is patient safety. You are offering anticholinergic to a patient who has a history of glaucoma. You think that, oh my God, I have spoken so nicely about anticholinergic. I am going to get complete marks because I was to the point. I told about allergies. I told about, doses and how to repeat, when to come again, telephonic consultation, everything. I don't know why I couldn't clear the exam. Probably you didn't ask her health condition. Probably she was a case of glaucoma where anticholinergic was completely contraindicated. And most important, being empathetic doesn't mean that you will be dishonest. I have seen this confused. Please, everybody, mute yourself. Everyone, please, it's a request. Okay, so patient safety. What is patient safety? Please, everybody, take picture of this. Just take snap of this. If anyone is who is not able to clear this domain, please make sure whether they have missed anything in this. Confirming name and age in the beginning, then confirming this in the report, then talking about any kind of allergy, then talking about medical or surgical. Why these are so important? Just imagine that patient has come, that the patient is primary. She has come to understand about options for mode of delivery, but you didn't ask about the surgical comorbidity, and probably she has gone for myomectomy 6 months back when there was a big intramural fibroid of around 8-9 centimeter which was removed. So anyone, whether she is a good candidate for cesarean section?
Yes, ma'am. Yes, ma'am. If cavity has been breached, then the cesarean section is like safest option for her.
Yes. Whether she is a good candidate for normal delivery?
No.
Yes. So, if you forgot to ask surgical comorbidities properly, or even if she mentioned about myomectomy and you didn't register it, sometime what happens that we go with the flow so much that we are more concentrating on what we are asking. We are not concentrating on what she's saying. And somehow, for part 3, you have to be a very good listener. You have to be very good listener. For part 3, you have to be very good listener. This is very, very important. If she has informed you about like okay, any surgical comorbidity, yeah, I had a myomectomy, okay. Any family history of concern, probably you have not registered what she has said. And because she has a, then if she says myomectomy, you will immediately ask, okay, when you have got it done, do you have any details? I'll go through your case notes with your permission. Is it fine for you? Yes, doctor. So when we'll talk about mode of delivery, you are going to speak mainly about cesarean, mentioning that very clearly, honest about the facts. Please, girls, do not get confused with that. I have to be empathetic, so I will not say that you are taking or you are consuming cocaine, but it is not a reason of for your IUGR or IUD. Will you say something like that? I have seen that you all girls have this confusion, but it's not your fault. Probably you have been not taught you. Nobody has taught you that way. Do you agree with this? Yes. Sometimes you really get confused. Sometimes you really get confused whether can I speak this much? Will it appear very harsh? Won't I be appearing an like empathetic doctor? So somehow you become dishonest about facts. This is a very, you know, I can guarantee you, if all of have you gone through these 3-4 lines, you would be able to understand why you were not able to clear patient safety domain. Honest about the facts. You have to be brutally honest about your fact. I'm afraid, Zara, the normal delivery is not a suitable option or safe option for you. Reason, there will be a risk of giving apart or giving away of the scar which has been made during the myomectomy. That is the very thinnest and the weakest part of womb. The cesarean section that is in a planned way is the right option for you. You are not like a harsh doctor. You are an honest doctor because see, it is not necessarily if I'm talking about something honest, I have to be rude and rough. I can say even brutal truth with very soft voice, with very mild words, being very modest. And I can be very, very honest without hurting her sentiments. I have to speak truth, but with milder tone, milder language, milder words.
படிக்க போ சச்சா.
Am I clear? Girls, do you see? I want communication. Girls, you are not responding at all. I don't like this.
Yes, ma'am.
It becomes so boring. Who is this? Fatima?
Yes, ma'am.
Please respond. Everyone, girls, please respond. Amna.
Yes, ma'am. You are very right. Actually,
Amna, Anam. Now everybody will say hi to me. Amna?
Yes, ma'am.
Okay. Kaisa?
Yes,
Anam?
ma'am. Yes, ma'am. Very clear.
Yes. And this is if I wrongly pronounce any name, please pardon me for that. It's Dai Al Kamar. Am I pronouncing it rightly? Say hi to me. Beena, hi. Manoj, hi. Ruma, hi.
Ma'am,
Dr.
I'm Purnima actually.
Purnima.
Hi, ma'am.
Yes, yes.
Okay. Okay. And Rekha, hi. Saroja, hi. Sunita, hi. Yogpriya, hi. This is Z Fold. Dr. Anjali, Faizia, Samina, everybody, hi. Now be very, very active in this thing participation. Otherwise, it becomes so boring. Okay. So everybody, now you understand how you can clear this domain easily, just remembering her name and it, just confirming this, just asking drug allergy, just asking medical and surgical, just asking Jehovah Witness, just asking blood group, just addressing her concern, whatever concern she has, and you have to give her correct evidence-based management, contraindication as per health condition, very important and honest about fact. If you cover all these points, there is no reason that you will won't be able to clear your patient safety. Next, communication with patient, you have to be empathetic, sensitive. Emotions. Emotions means when and not being monotonous, that is very important. You have to give ups and downs. Sometimes you'll speak in sort of slightly higher volume, then you'll become in low in your volume, then you will become very empathetic, then very simple, and most importantly simple. And very important, whatever choice she has come with, even if you find it very shitty idea, please appreciate her. Please appreciate her. She had 3 cesareans and now she is 4 times pregnant and she is talking about normal delivery. It will appear quite shitty idea. Still, please say, okay, I appreciate your this thing. Even if you think in your mind, but what the hell she is talking? What is she asking for? What an idiotic idea. Still, please be always start with appreciation. The way you get feedback, you're always your mentor say, oh my god, I'll take one name. Okay, whose name comes first? Okay, Sunita, look what a presentation, how sympathetic you was, you have taken good information gathering, this, then they start giving the feedback which is negative. But you have not done this, but you have not done that, this was not right, right, Sunita? Sunita, will you unmute yourself? Okay, Yogpriya, every time, first your mentor always appreciate you, always tell about the good points, then we talk about the negative points, right? Then we talk about the points, right? So same way, whenever patient comes with any idea, first you have to talk about the best.
Hello,
Yeah.
ma'am, am I audible?
Yes, very much.
Oh,
So communication with patient, you have to be very empathetic. You have to be sensitive. I prefer being more sensitive than being empathetic. Emotions, you have to show your emotions. It should come on your face that you are feeling bad about her. It should come in your eyes that she is crying and you're feeling her pain. It should come on your face. And don't never be monotonous, that there's one tone. Okay, I understand that it is very wrong. Oh my god, this has happened to this, and there's no emotions, there is nothing there. So it is like it appears as that many a times when I give my feedback, I tell my student that it is appearing that you are reading some news. Though the lines are very empathetic, okay, it is so, I understand that it is so difficult to take it, how you are coping with it, but it is appearing that you are reading newspaper because there is no changes in tone or nothing. It is going flat. It is going absolutely flat. If somebody is doing acting in picture with flat face, right? Again, please make it simple. Even you are communicating with patient, they are not going to judge on your English. They are not going to judge you on your grammar, but try to make, don't try do any grammatical mistake, that I would request. But there is no need that you need to use very high-fi word for anything. You can speak very simple but correct English. Simple but correct English. And always appreciate for whatever ICT idea she has come with. Now, communication with colleague. Saroja was talking about. Saroja, if you are there, MDT, GP, and one more thing which is very important, whenever you need to include counselor during information gathering. I repeat, whenever you need to include counselor during information gathering, do it then and there. Do not wait that once I'll reach to MDT, when then I'm going to address that. No. When she's saying that I'm feeling so depressed, I'm not able to cope up with that, you have to address that then and there, the way you do in case of smoking. You offer stop smoking center then and there, right? Or do you wait for MDT?
Hello, ma'am.
Yeah.
Yes, ma'am. That time only will address the
Yes,
patient.
the same way, where the way you address stop smoking center then and there, the same way you are going to address her psychosexual counselor, her normal psych counselor, that is emotional counselor, then and there. When she's saying in support, okay, whom do you live with? I'm staying alone. Okay, so how to, if she has come for, say, endometrial carcinoma, probably endometrial hyperplasia, and she is staying alone, then and there you will offer her support. When she's saying that I'm staying alone, and you are aware of her diagnosis that she has come with the endometrial hyperplasia and we have to rule out endometrial carcinoma by biopsy, you will offer support. If you want, we can offer support for you from our side. If she says yes, then say, okay, I'll inform my senior midwife, or I'll inform the social services. If she says no, then it's fine. Offer then and there. So many things you will offer in information gathering. So in that case, you will not miss communication with colleague. In teaching, you have to be friendly, not bossy. Again, same formula. Appreciate first, then flaws. This formula you have to apply everywhere, whether it is you're dealing with a colleague, whether you're dealing with patient, that you have to appreciate first, then flaws, and ask what she knows. In teaching, if you do not ask what she knows, then you are compromising with communication with colleague, because you don't know what all she knows and what all she wants to know. So if you do not ask this one line, you are communication with colleague compromising in your teaching station. I repeat, if you do not ask what she knows. Okay, she has come here to understand about CTG. If you do not ask about what she all knows about CTG, can you give me some idea, Zara, what you understand when we say CTG? So if you do not ask this question, you are compromising communication with colleague. So again, these friendly, everybody knows. Do not be bossy, everybody knows. Appreciate first and then flaws, everybody knows. Probably everybody doesn't know about this. That if you miss this point, you are compromising communication with colleague in any teaching station. Now, information gathering. HOPI is the question which is pertaining to that particular condition. You will always ask with this. If it is pregnancy with some medical condition, so you can ask pregnancy first, then medical condition, or other way, like medical condition first, then the pregnancy. If it is just say overactive bladder, then you are going to ask the other symptoms of overactive bladder, and you will rule out other condition like SUI, like prolapse, like any cancerous condition, etc. in HOPI. After that, from here till here, this is a routine information gathering. Always divide your information gathering in two parts: HOPI and routine. Routine, obstetric, gynae, medical, and then allergies, surgical, family history, occupational history, support, mental history, personal history, this, blood group, Jehovah. Thanks for giving information. So, Manoj, you were asking. So, this is the first part of your template.
Okay, ma'am.
No,
Yeah,
this is
got
first
it.
part of your template. HOPI, in HOPI, you will ask about the condition. Then obstetric history, gynae history, medical history, and the allergies. This is easy to remember that when you ask about the medical history, any medical condition of concern, are you taking any special medication? Are you allergic to drug or for anything? Any surgery that's on tummy or down below? Few students do say that if they find this question very weird down below, I understand. Even I don't like this word down below, but unfortunately, this exam is not designed as per my choice. This exam is designed by a college, and they have their own way of dealing with patients. So, why this is important to ask about, particularly tummy or down below? If you say any surgery in past, if you get any fussy, notorious role player, which will say, yes, I have a surgery on my nail 10 years back, and then she'll start explaining the surgery about her nail, which has no relevance with your tasks. Am I right or wrong?
Yes, ma'am.
Okay, so if you get any notorious, any role player which has been instructed that if your candidate is not to the point, just let you also beat around the bush. If she is beating around the bush, you also do same. Then she'll start talking about surgery which was done for her teeth, which was done for her ear, which has no relevance. She has a fracture in her upper arm, which has no relevance with your surgery, with your condition. But that will waste your time. So always ask particularly any family history of concern. Do mention blood clots, legs and lungs because they are very finicky about DVT. Very college is so finicky about DVT. I don't know, but they are. So do mention any family history of concern like DVT, blood clots in legs and lungs. Do not mention everything, blood pressure, sugar, thyroid. She will definitely mention. Now, one very important point, when there is a condition which is related to cancer like endometrial hyperplasia, patient has come with, and you have to rule out whether she has any family history or patient is coming with the condition like bloating or this thing, you have a doubt of ovarian cancer, then you have to rule out cancer in the family. And when you say if there is any family history of concern like any cancer in breast, ovary, or bowel in male, immediately the next question by role player is that why you asking this, am I having cancer? Then how you are going to reply? Any volunteer? Any volunteer?
Ma'am, we can say, ma'am, shall I?
Yeah, sure.
Yeah, ma'am. Ma'am, we can say, no, Astha, please don't thinking that way. It is not a cancer, but if left untreated over a period of time, it may turn into a cancer.
No, but when you are asking, let's say patient has come with a cyst and she has a complaint of say bloating and this and that, but you are not sure about the because it's a just given you have been given with a scan which is showing a 6-7 centimeter ovarian cyst and you are even not sure whether it is a cancer or not. So you cannot say all these lines.
Yes, ma'am. Ma'am, then we can say that no, it is not a cancer, but
What if it is a cancer? How can you say it is not a cancer? Probably it can be a cancer. How you can be
okay.
so sure? Okay, Rekha
Uh,
wants to try. Okay, Rekha.
I will say that at this point, I'm not sure whether it is a cancer or not, but with the further investigations, we know that either it is the cancer or not. So I think,
Again, it's very long. I always say, Rekha, make it simple. It was right,
yes,
but
ma'am.
it was very long. Anybody else who wants to try?
Ma'am, we can say that having a cancer in the family
Hmm.
adds some risk factor in can add in some risk factor into your history. It can be a risk factor.
Yeah, but again, this is an answer where role player can stretch you further and can waste your 2-3 minutes.
Yeah, exactly. You're right. So,
Anybody else? I will simply say, Zara, do you have any family history of concern like any blood clots, legs and lungs, or any cancer like ovary, breast, or cancer in bowel in any male? Why you're asking this question, doctor? Am I having a cancer? No, Zara. I just want to understand your condition better. Simple. Right or wrong? Why
Yes,
you
ma'am.
want to ask
Right.
this question? Because you want to understand her condition better. No, Rekha. Why
Yes,
you
ma'am.
want
What
to
you
have this
say?
condition? Because you want to understand her condition, whether she is
Yes,
having a
yeah.
cyst, if she has a history of bowel cancer, whether she is having a history of breast cancer, probably she is a case of BRCA, probably she might be a case of Lynch. So this is the fact, no? This is not you are just trying to, hide something. This is the fact because I want to understand your condition better. So sometimes speaking truth is the easy way to get rid of any condition. Rather,
Yes,
most
ma'am. You
of
are
the
right.
time, speaking truth is the getaway with any condition very swiftly and very smoothly. Speaking truth is the easiest way of coming out of any difficult situation. I want to understand your condition better. That's it. And after this, do you think, Rekha, she will be having any other questions?
No, ma'am. Yeah, you are right.
So, is it clear, Saroja, who was the first one who replied?
Ma'am, it was me, Kaisar.
Yeah, Kaisa. So, do you agree with this?
Yes, ma'am. Yes, ma'am. Ma'am, one point is there, if a patient is having ovarian cyst and now she is telling that, is it a cancer? Ma'am, then what can we say at that time to her?
If she says in the beginning itself, then address her concern then and there on the basis of report. Just suppose if she has come with the CA 125, which is say 50, 60, 70, and you have, once you will go through tasks, you will calculate her this malignancy index, right?
Yes, ma'am.
Okay. If she's saying that whether I am having a cancer, I would suggest, if she has a probability of cancer, please address her then and there. That on the basis of an evidence-based calculation for calculating the risk of having cancer, which we call it as RMI, it is coming 900. I'm afraid, or I'm sorry, Sarah, it is giving a risk or very high risk for having ovarian cancer. That is approximately 7 out of 10 women. Again, honest with facts. Don't run away with truth.
Yes.
Because if you will not answer her, again, you are compromising patient safety because you are not addressing her concern. Evidence-based management, it's a fact. She has CA 120 RMI. She is having 900, 800. She has high risk for ovarian cancer. No. So you have to say this brutal truth with a very straight, simple, and straightforward line. I'm afraid, yes, there is a risk of 7 out of 10 women. 70% women would be having the
Yes, ma'am.
risk. High risk. You will not say that you have cancer, you do not have cancer. For that, you have to go for CT, no?
Yes, ma'am.
So, how will you say? I'm sorry to say that this much RMI, which is evidence-based calculation for risk of ovarian cancer, is very high, which is indicating that with this RMI, 7 out of 10 women would be having the risk of this ovarian cancer. But for confirming that, we need to do certain tests further. Can I talk about that later on? Because taking your history or information is equally important to decide about that. She will never say no. She will never say no. She'll say, okay, doctor, because you have given her answer. That probably, I can't say that you are having cancer, but a girl, a woman with you with this condition, 7 out of 10 women. If she says, I am having cancer, you will not say you have cancer or you do not have cancer, because you do not know that. You will say that this calculation is indicating with this finding, there is a high risk of ovarian cancer. But to confirm that, we have to conduct certain tests as well. I'll definitely address later on. Before that, I need to know more about you. Can I go ahead, Zara? She will definitely say, yes, doctor. And this is patient safety, that you have addressed her concern and now you're moving forward. And later on, when you will explain the diagnosis, please do not repeat that again in the second part of the task. In the second part of the task, you'll start that. Okay, I'll confirm your name and HS number. This is belongs to you, and this is showing the sisters of this size and this A125 confirmed. As we have just discussed about RMI, you have a high risk of this, 7 out of 10. So now you will be referred to expert team, and with the CT scan, this will be done within 2 weeks. And on the basis of CT scan, expert team will decide whether you are again low risk or high risk for ovarian cancer. When you are high risk, then you will be referred to oncology hospital. Then you will talk about both the exploratory laparotomy, and then if it is low risk, then you will be referred to any the cancer center in any hospital, and you will be held by the gynae cancer specialist. Then where we are going to remove uterus tube and the this lining of bowel, etc., etc. This is the algorithm you are going to follow. right?
Yes, ma'am.
But
Ma'am,
that
it's clear, ma'am.
particular RMI and this you will skip because you have already explained, so do not repeat it. Because you have not explained her cyst report. Even if you want to explain cyst report there when she was asking cancer, you can do that. That okay, I have confirmed your NMHS. This is scan is showing that you have this much cyst and the CA125 RMI is this much. So this much RMI is showing that high risk for the ovarian cancer. That's 7 out of 7. But it's difficult to say that whether you're having it or for that we have to do certain other test, which will definitely address in some time. Before that, may I ask you a question? So once you reach to explaining the diagnosis, you simply say, we have already discussed about that. So now we will we refer you to expert team and we'll do a specific imaging test. We call it a CT scan. On the basis of that, we'll come to know whether what is your cancer risk. Because even after that is a high risk and low risk. Even after CT and MDT is high risk and low risk. Because the confirmed diagnosis only after tissue testing. Right?
Yes, ma'am.
Even after the CT and this thing, we say low risk and high risk. So if you have explained everything in the beginning, please do not repeat. So now moving further, spatial imaging technique, expert team. And after combining this, they will come to conclusion whether you're low risk or high risk. In case of high risk, this is the spatial surgery. We call it exploratory laparotomy. You will be referred to this. If it is a low risk, this. Final diagnosis only possible after tissue testing, the tissue which will remove or the part which will remove from your body. And then 2 weeks, that fast track you will definitely mention. In the end, you will talk about GP reference, you will talk about support group, you will talk about written information. And now here you will not say, I will refer to you consultant. Now you will say, we'll do the needful for arranging the CT scan and then the meeting with expert team. Clear? Who asked this question?
Yes, ma'am. Yes, ma'am. It's clear, ma'am. Thank you.
Clear? Okay.
Yes.
So this is all about this. Then family history, then occupational history, then support. Then again, occupational history. If she is like, if she has a history of ectopic pregnancy, and probably she may need to go for surgery, but she's a teacher. And if you ask that, what did you do? She says, okay, I'm a bank manager, I'm a teacher, and but she needs to get admitted. So what will you do? What will you do? You will offer her
Sick leave.
sick note. Okay. Now support. She says, I'm very depressed, I'm this and that. What are you going to offer her? In mental.
Psychological counselor.
Sorry?
Ma'am, psychological counselor.
Emotional counselor. Say emotional counselor. Again, it is SPT, no?
Emotional counselor.
Then
Emotional
cancer
counselor.
history, if she is smoking, now, who will answer this question? If she says that I smoke 8 to 10 cigarettes in a day and she has come for the preconception counseling, who is going to reply this?
Ma'am, I'll say that smoking is not good for health. I will offer you, if you what's your idea about quitting smoking? I can connect you to the NHS Smoking Stop Services program. So how does it sound?
I'm not interested. Why are you guiding me? I'm not interested for quitting smoking. Why are you saying this, doctor? She will pounce back on you.
Ma'am, can I reply?
Yeah, sure.
Yeah. So I will say that
No,
let's say
no. Fatima, present that. Be
okay.
a role player and present that.
Okay, so Zara, I totally understand your concern. Sometimes quitting habits are very difficult. So let me tell you that smoking is injurious to your health as well as it is injurious to your baby health as well. So for getting healthy pregnancy outcome, it's very important to stop this smoking, and for this I can offer you a help. Like we have a program that is NHS Stop Smoking program, so I can connect to you. And
It's
I'm
very
sure
good, Fatima, but again, it took almost 1.5 minutes. We don't have that much time. Try to make it shorter.
Can I try, ma'am?
Who's this? Rekha? Yeah, sure. Do not take more
Smoking.
than 40-50 seconds. No, do not take, okay?
Yes. Smoking is harmful for you and your baby. If you wish, I will put you in touch with the NHS smoking services.
I know that it is harmful, doctor. I don't want to quit. She'll be very, very rude with you. Rekha.
Okay.
Anybody else? Have you ever thought of quitting smoking? You have to
I
start.
understand, ma'am. Can I?
Yeah, sure.
I understand that. So what is your question? The patient is smoking 5 to 10 cigarettes. Okay, I will tell the patient that Sarah, smoking is injurious to both you and yourself, your baby. But even if you're quitting smoking in as of now, uh, the mm, it will reduces the complication, the future complication.
Frankly speaking, you all are correct. Fatima was right, Kesar was right, Rekha was right, you're also right. I just want to make it shorter. Just make it
Ma'am,
short.
first we will ask about her thoughts that either
Yes.
she ever
The
tried to
very
cut down
first line, the
smoking.
way, yeah,
Mm.
all, yes, yes, very
So
first.
have you tried to cut down smoking, and
Yes,
whatever she say,
yes.
then if she is trying to stop smoking, then we will appreciate her that you are doing good. And if you need any help, so because it has some implication on you and your baby, and we will put you in touch with NHS smoking service.
Yeah. Make it simple and always make a rule. Never say. All of you have said that it is going to have injurious health or dangerous effect or whatever effect on you and your baby. Never, never, never say you. Even a patient is coming with 40 BMI and you are explaining
And
her.
with the third person, we will say woman
Yes,
who smoke.
yes, yes, yes. So, Amna, you have like correctly messaged us that have you ever thought of quitting smoking? You again, I always say, na, ask her concern. Have you ever thought of quitting smoking? If she says yes, then your job is done. Then we'll say, okay, I'll touch you in, I'll put you in touch with the stop smoking center. Then you have no need to say any other thing because she's herself saying that I want to quit. But if she says no, then you have to say, it's fine, Zara. But just for your information, pregnancy has detrimental effect on pregnancy and women's health as well. In future, whenever you thought of quitting it, do let us know. We'll put you in touch with Stop Smoking Center. Do not stretch any point too much that it pokes her. Never poke your role player. Never poke your role player because once you will poke, she will poke you back. Okay? Always say the first line that have you ever thought of quitting? She says yes, your job is done. Very good. I appreciate that. I'll put you in touch with that because it has bad effect on your in someone's health in the pregnancy as well. But if she says no, then say it's fine. Just to inform that it has bad effect on pregnancy and the women's health. So in future, if you think of quitting it, do let us know. Even if you say this, okay, it has bad effect, she'll say yes, I know that. Do not retaliate. You are not supposed to retaliate on role player's reaction. If she said, I am aware of that, doctor, you may find some, I am aware of doctor that it has bad effect on my health, but I cannot quit it. Then it's fine. Simply say, in future, if you want our help, we have Stop Smoking Center. In spite of her, this retaliation, say very gently, very mildly, in future, if you want any help, we have Stop Smoking Center. That's it. Your job is done. Clear, everyone? Everyone, is it clear? Say yes or no.
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
Okay. Then same with the alcohol, same with the recreational drug, blood group, Jehovah Witness. How will you say or how will you rule out Jehovah Witness?
Ma'am, do you accept blood?
Any reservation of the blood.
Transfusion. So
Hmm.
what the patient is going to say,
If you
doctor,
accept the blood if required.
if required. If required. Because if you say any reservation about blood transfusion, her second question would be, do I need blood transfusion? So do not give any, do not leave any space for asking any unnecessary question and wasting your time. Okay? Blood transfusion if needed or if need arises of if required, whatever the sentence you want to speak. Okay? No, never. Never, Amna. Saying that you are Jehovah's Witness is very derogatory. Very derogatory. Okay, Amna? Never, 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 never say you are Jehovah's Witness. It is very derogatory because unfortunately Jehovah's Witness is related to certain religion. If you say something like that, somehow you are going into their personal space. Okay? NBMI. What is the relevance of asking this question? Thanks for giving information. Anything else which you want to add in this?
Ma'am, if we left any information they
Yes.
want to add, they can add.
Yes. So always say thanks for giving information. Anything else which you want to add in this? Okay. So this is about information gathering. Now applied clinical knowledge. BBN includes safety, communication, applied clinical knowledge. Definitely. Again, I have seen so much of confusion about BBN. Most of the students do not do BBN. BBN is breaking bad news. Breaking bad news can be of three types. Breaking bad news can be mild. Breaking bad news can be moderate. Breaking bad news can be severe. Who is going to explain me what is the difference between three?
Ma'am, severe means if the patient is suppose having the cancer. In that situation, it's a serious condition. Like if the baby is IUFT or like having any
So
serious congenital anomalies which is incompatible with
how
the
you are
life.
going to do BBN in severe BBN?
Yeah, in the severe situation, first of all, we have to make the first of all, we'll say that do you want me to? Yes.
Say it.
Okay. Do you want me to call someone to be with you, as I have to give you a lot of information? Then I will say that I have some serious concerns to discuss with you. I'm afraid that the news is not good as we are expecting. So, yeah, I can say that I have some difficult news to discuss with you. Then I will straightforward give the BBN. Like I will say that I have confirm your name and NHS number, and your scan report shows that you have the cancer in the womb. Then I will keep silent for the 10 seconds. And afterwards, I will say that if you want, I'm sorry to be bearer of such news. And do you want me to continue the consultation? And if she is crying, whatever the reaction of her, then I will offer her tissue papers, whatever her reaction.
Okay, nice. Then if it is moderate, so when it is severe, you are going to say, I have some difficult information to share with you. When it is moderate BBN, then you will say there are some concerning information to share with you. When it is mild, then you are going to say there are certain information which I have to share with you. So for mild, I have certain information or I have lots of information to share with you. For moderate, you are going to say I have some concerning news or information. But for severe, you are going to say straight away that I have some difficult information to share with you. Am I clear, everyone?
Dr. Pooja, when we are creating like the environment, so does it involve any warning shot?
These are warning shots only. These
No,
are
like we
warning
are
shots.
saying that do you want to call someone? So this is the
Basically,
environment we are creating,
basically,
na?
we give two warning shots. So
Yeah,
I
I know.
will start. I can see that you are alone. That is one warning.
Okay.
Second warning shot, that I have to share lots of information. So these are two warning shots. When you say someone, Rekha, that I can see that you are alone. So you get alerted. Why you're saying this thing?
Okay.
Okay, you have come alone. So this is alert. They have given you an alert. So that is one warning shot. I can see
Warning
that
shot.
you are
Okay.
alone. Second warning shot, I have to share lots of information. Now she's prepared.
Okay.
Two warning shots with before BBN, two warning shots. For mild, lots of. For moderate, concerning information. And for severe, difficult information. Everyone, am I clear about that? How will you differentiate?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay, so Ruma, can you tell me what is mild, what is moderate, and what is severe, and what is the difference between the type of information?
Ma'am, the severe one, that I have some difficult news to share with you. The moderate is I have some concerning news to share with you.
Lovely.
And the mild is that I have certain information to share with you,
Lots
and
of it. Very good.
lots
So
of
I hope I'm
information.
clear about BBN now.
Yes.
Yes, ma'am.
Right. Amna, I'll address your concern in a while. Let me finish this, okay? Amna, I'll definitely address you this thing, okay? No issues. So after that, so BBN is covering your safety, because if you have not given a BBN shot and you have blasted, you have compromised safety. Communication, of course, applied clinical knowledge. Then you will explain diagnosis. I have seen that you all have tendency of explaining diagnosis in 5-6 lines. Please do not do that. For PPCM especially, I have noticed you have to say that heart weakens and not able to pump properly. That is PPCM. Right? Because do not forget that you don't have that much time. You don't have that much time, right?
Yes, ma'am.
Okay. And then so first, second part of the task will start with BBN. Then you will explain diagnosis. Then after diagnosis, you will tell her what all the complications she is going to have and why she has this diagnosis, means all the risk factors. If it is there, then impact on pregnancy, maternal and fetal both. And pregnancy, maternal, fetal both, and other way, like effect of pregnancy on condition itself. Sometimes because of the pregnancy, condition also deteriorates. So condition has impact on pregnancy, mother and baby, and pregnancy has impact on condition. This you are going to mention here. Then you are going to involve MDT. Then you are going to give timeline. Or if it is pregnancy, then antenatal, intrapartum, postpartum. If it is gynae, then give proper timeline, lifestyle, medical, conservative, surgical, etc., etc. At the end, you will offer support group, PIL, GP, and always say thank you. Am I clear about applied clinical knowledge? Yogpriya,
Yes,
are
ma'am.
you there? Yogpriya, are you there? Yogpriya is there?
Yes, ma'am. Yes, ma'am. The last 4 lines, till MTT, I was the last
What
three
you
lines.
do? What you do? Just take picture of this, take a print
Yes,
out, stick on your table, the wall in front of your table, stick that. And see this
yes,
at least 4-5 times. You will see automatically when it is in front of your eye, on your sitting table or on your workstation. Just stick it on your wall. You will see it at least 5-6 times in a day. Unknowingly, it will register in your mind. Whenever you try to remember something, there are 3 ways of remembering it. It is like speaking it, hearing it, and watching it. If you do all 3 things together, it is going to register in your mind. When you see it, say it. Okay, support group, PIL, GP. Okay, support group, CIL, GP. You will never forget. Okay, Priya?
yes, ma'am. Sure, ma'am.
Take a picture of this, take a printout, and put it on your wall, on your workstation. So now we are going to start with labor ward prioritization. I'll just take a break of 5 minutes because it is 1.5 hours already. So first I'll give you idea about situation, background, assessment, recommendation, because it is very, very important in labor ward prioritization. Situation is the concern. Situation is the concern. Yeah, what is the concern here? That what is the concern? Who can tell me what is the concern here? What is the concern here? This man can.
So climb the wall or
Die.
not?
He's not climbing.
Yes.
He's not climbing. He has slipped from the mountain. He might fall.
Fall down.
Yes. So this is the concern. And what was the background? He was nicely walking on his path. This was his background. This was his background, right? Right?
Yes,
So
ma'am.
this is the situation. Concern. What is our concern? That we have to save this man because he may fall down at any point of time. So this is our concern. And what was the background? That he was going back to his home. And what is the assessment? You are going to assess his condition, how much strength he has to be in that position until we get some help. So that is the assessment and the recommendation. In recommendation, what you are going to do, you are going to ask that man to have some patience. We are calling someone, we are getting some rope, we have called ambulance, we have called help. So this is your recommendation. This is how you are going to present. This is how you are going to present any labor ward prioritization. First, situation. Second, background. Third, assessment. Fourth, recommendation, which we are going to discuss. Now, Sunita is asking which one is the mild, which one is the moderate, which one is the severe. Severe when there is cancer, severe when baby is already died inside. These are all the severe condition. Pulmonary hypertension with pregnancy, this is severe. Somebody is already been diagnosed with cancer, it is severe. What is mild? Mild is like somebody is having controlled grave disease and now she is pregnant. Okay, and what is moderate? Moderate is something like she is pregnant and probably she has uncontrolled graves. This is moderate. Mild is something she has some condition, but she has that condition in a very controlled way. Overactive bladder, it is mild BBN because she's not going to die with the overactive bladder. But she has to have certain treatment, she has to have certain investigations, she has to go for surgery at well. So this is going to be mild. I have to share lots of information. Mostly gynae conditions are mild unless it is a known cancer. If it is atypical endometrial hyperplasia, it is not a mild. It is not severe as well, but definitely it is moderate because she may have cancer. Clear? Saroja?
Yes, ma'am.
Sunita, am I clear about this? Okay. Now Amna was asking, how can we access how much she is strict in her religion belief to accepting blood transfusion? The first line you have to ask, may I know your blood group? Second, do you have any reservation about blood transfusion if needed? If she says no, there is nothing left to be asked. If she says yes, then rather than asking why this and that, you will say whether you have this refusal or whether you are willing to have any component of blood, or are you willing or you are not okay with any component of blood or the complete blood. Sometimes they are not okay with whole blood, but they are okay with some component of blood. Like they are okay with platelet transfusion, but they are not okay with the whole blood transfusion. They are okay with any kind of, fluid transfusion, but they are not okay with platelet transfusion. So you will say specifically, do you have objection for any component or the complete any kind of blood transfusion? She'll say, I am not okay with any kind of blood transfusion. Are you okay with any fluid transfusion that has any protein or salt? She'll say yes or no. In case of emergency, can we use your own blood? We'll filter it and we will give it back to you. Are you okay with it? You will rule out that condition that way. So first, when you will say, if need arises, do you have any objection? If she says yes, so that is for complete blood. Or are you okay with any component of blood? If she says yes, no, whatever, then are you okay with the fluid which has any kind of protein or salt, whatever, if she says yes or no. In case of any emergency, is okay if we use your own blood, filter it and give it back to you. If she says yes or no, probably she'll say yes. In that case, they say yes. Okay.
Dr. Pooja, can you repeat it once again? Sorry.
Okay. Who would like to repeat it for me? Let me see who all are attentive in the class. No one. Rekha? No one.
Yes, ma'am.
Who wants to repeat? Rekha, nobody is listening to me.
Ma'am, I can
repeat?
repeat.
Who's this?
Yoga Priya.
First, I will ask about
Priya,
her.
let Yog Priya do. Rekha, let's see. Yeah, Yog Priya. Shoot.
Ma'am, with the patient with Jehovah's Witness, I'll be asking to the patient, I'll be asking, may I know your blood group? Any reservation for transfusion if required? The patient says no, then I will be asking, okay, so what are the blood products would you like to have in case of any emergencies arises? Patient says, no, I don't want anything. then we have to make a note of it. Or I will be asking whether your blood can be used in case of any emergency, or we'll be using any proteins or salt fluids which is contained in it, or any sort of blood cells other than the red blood cells that will be used. Would that be okay with you? Like that, I'll be asking to the patient in case of Jehovah.
Okay, so now Rekha, you become her role player and Yogpriya will answer.
Okay.
Yeah, come on, Yogpriya. She's your role player. Be very systematic. If you're talking about blood product, then you talk in like first about blood product, then the second, then the third.
May I know your blood group, Rekha?
Yes, B negative.
Mhm. Any reservation for blood transfusion if the need arises?
No, I don't accept any blood.
Mhm. So, in case of any emergency, like any excessive bleeding, your blood may be recycled and that can be used in case of emergency. What we call it as intraoperative cell therapy. Would that be okay with you?
Yeah, that will be fine for me.
Mhm. Or else any other blood products like any fluids which is containing salts and vitamins that can be used in case of emergency.
Yes, I will agree about that, but I don't accept any blood.
All right, all right. I make a note of it, and if the need arises, we will do the needful. Thank you.
Oh,
So basically, first, if she says no, yes, I have objection, then you will specifically ask that whether you have objection about any particular component, right? If she mentioned that I don't want this red blood cells or platelet, if she is aware of that, you I do you have any like particular component you are not okay with it. First, you will confirm that. After that, you are going to talk about any fluid which has salt, protein. Are you okay with that? In case of any emergency, if you take your own blood filter or recycle it and use it again. Okay.
well, for the NTD, we will say the same. Like if the patient is having the blood group negative and blood group, so we want to give her NTD. So what about the NTD? We will ask.
So how will you say? Do we offer NTD to every RH negative?
No, if she suppose her blood partner, if she already received the NTD in the previous
So
pregnancies or through.
now Yogpriya, you become a role player and Rekha will address you and talk about RH negative.
Okay, so may I know your blood group?
Yeah, I'm B negative.
Okay, do you accept the blood if need arises?
No, I don't want to go for any transfusion.
So do you have any objection to the particular blood products or?
Yes, I have served in it. Like I don't want any the blood directly going into my body. That
Okay,
I don't want specifically.
I respect your wishes, but if in case need arises, so if any emergency arises, so do you accept the if we give your blood by filtering through the machine,
Yeah,
your
can be
own blood?
considered.
Okay,
Yeah.
so I can see that your blood group is negative. So have you received any injections in your previous pregnancies, like NTD?
All right. Yeah. Yes, they have given me
Okay,
that to
so we
prevent
will.
my baby jaundice. The nurse, the
Okay,
midwife.
okay, ma'am. So she is already receiving that. So of course, so it means that she is having no objection.
Okay, so now you're clear?
Yes, ma'am. Yes, yeah.
So I'll take this 5 minutes break. We'll come back. Discuss labor ward prioritization. There are 5 rooms which we are going to discuss, and I'll give one room to everyone. So if anybody who wants to volunteer, please just text in chat box. Okay. I'll take just 5 minutes break. Everybody go have some water, come back. Okay, so now we have volunteer Rekha, Ruma, Fatima, Yogpriya, Kesar. Okay?
Yes, ma'am.
Ruma, then Fatima, then Yogpriya, then Kesar, right? Anybody else? Because we have 5 rooms and I want at least 2 girls presenting 1 room. Okay. So just go through this and try to remember what all we have. Okay. Now what we are supposed to do, what needs to be done, why needs to be done, and who's going to do that. Okay. So now these are the rooms. Rekha?
Yes, ma'am.
Situation, background, assessment, recommendation. Your time starts now. You have to finish
Okay.
this. I'll give you some rough idea, everyone. So it won't take much time and you will be able to understand how to present. When we say situation is the concern. Why she has come in the hospital or emergency or in the labor room. In background, what's her age? What is her gravida? And if she has any condition, so what is the status of condition? In assessment, you are going to ask her vitals, her any comorbidities if she has, her abdominal, vaginal, CTG condition, if whatever condition she has, so what is the current control? Specifically, if she has sugar, if she has blood pressure. In recommendation, please listen to me carefully. In recommendation, the first 2 things you are going to say, whom you are going to delegate this task and what is the priority level. So how you are going to prioritize and whom you are going to delegate. This is the first 2 recommendation. After the third point, what all you are going to recommend. Am I clear about that, everyone? Yogpriya, Fatima, whoever is going to present. Recommendation first, prioritize. Second, delegate. Then third, speak what all you are going to do with that patient. So your time starts now, Rekha.
Okay, ma'am.
Yeah, speak.
I'm reading the one. 1 second. Previously, I was listening to you.
Okay,
1
only room
second.
number 1 you have to present.
Only room number 1. Okay. Okay, so room number 1 with diabetes mellitus for the induction of the labor. She is 35 years old, gravid to para 1 and L1, 39 weeks. So here I would like to know about her vitals, blood pressure and the pulse.
Wait, let me answer. She has normal blood pressure and pulse.
Okay, and what about her contractions and CTG?
Nobody has examined her. CTG is fine.
Okay, so I would like to review her ultrasound report for the weight of the baby and amount of liquor.
Okay, the weight is around 3.9 kg and lighter is fine.
Okay, so my recommendations will be I will also rule out her allergies, also any other medical comorbid she is having, and any other concerns she want to address. So I will deal with that. And also, for it's a semi urgent case, I will send my midwife here. She will going to apologize for the delay and do her CTG and check for the bishop, and we will do the induction once we will free from the other rooms.
Okay, anything else you want to add in this? In the recommendation especially?
CTG I have done. I think apologize for the delay and review her records. Bishop. So what else, ma'am, for the induction?
Or
I don't know.
DM. Whom
Yeah,
you
sorry. Yeah, sugars. And also once she go into the labor, then we will monitor her sugar and we will keep it in between the 4 to 7. If
and
we time allows, ma'am.
what should be the interval of checking sugar?
1 hourly.
What if she is under epidural?
Half hourly. No, in the epidural it is also 1 hourly, but if in the general anesthesia, then half hourly.
Don't you want to involve any doctor specialist in this?
Yes, anesthetics needs to be involved.
And
Ma'am, also consultant need to be informed and diabetes specialist, diabetologist,
diabetologist.
endocrinologist.
Diabetologist. ठीक है? Okay.
Okay.
And Amna introduction sentence is okay. Okay, for now everybody will first give the introduction, then we'll present the room. Okay. Okay. So anybody else who wants to present this room number 1?
Ma'am, can I?
Yeah, sure.
Hello, my name is Dr. Fatma, one of the exam candidate. I have read the instructions. I'm ready for the structured discussion. So I have taken the charge of labor ward at 8:30 and I will assign the cases to my staff according to their competencies, keeping in my patient safety at my utmost priority. My first patient is Mrs. XYZ. She is 35 years old, gravida 2, para 1, having 1 miscarriage. Keep it.
Fatima, situation, what is the situation?
She is here for the induction of labor. She is having a diabetes mellitus.
This is situation. Now tell background.
Okay. So my patient is 35 years old, gravida 2, para 1 with 1 miscarriage. She is at 39 weeks. So for this patient, I need further information regarding the patient vitals and patient vitals and Bishop score of the patient, and what is the type of the diabetes, and recent ultrasound regarding estimated fetal weight, liker assessment, and placenta localization.
And then recommendation?
So the recommendation is that I will inform my consultant regarding this patient.
No. First delegate and prioritize.
Okay. So for this patient, I will send my midwife and for checking all the records, checking the informed consent to do CTG and assess for the bishop. And after this, after doing all this, I will I want to see if any pain relief has been discussed in the notes. If she wants epidural, then I will involve the anesthetist. And for the diabetes, I will also involve the diabetic specialist and inform my consultant as well. And after settling the liver ward, we will start her induction with the continuous CTG. And for the diabetes, if she is type 1 or type 2, then I will start the sliding scale. That is 5% glucose with the insulin, and will check her blood sugar level 1 hourly with the continuous CTG. I will start the induction. And neonatologist will also inform regarding this.
Very good. Both of you have done nicely. So how will you do this? This is basically situation. Room number 1, Mrs. XYZ, for induction of labor in view of diabetes mellitus. It is SD. Try to be more systematic and talk like a doctor. So how you say it? Induction of labor in view of diabetes mellitus. Right, Rekha?
Yes, ma'am.
Yes, ma'am.
She is gravida 2, para 1, have 1 live pregnancy, a live delivery. She is in her 39 weeks of pregnancy. Do not read the task. Do not read task. She is gravida 2 with 1 live baby. She is in her 39 weeks of pregnancy. She is 35 years old. May I know, now listen to me carefully about assessment. 6 points you have to ask in all your assessment. Never start your room with prioritization. Reason being, unless you know or unless you have complete information of patient, how you cannot prioritize. For prioritize, for sending someone, you have to assess her first. Only then you come to know whether she is urgent, semi-urgent, or routine. Without assessing, you cannot understand whether she needs some attention immediately or we can wait for 2 hours. Right, Rekha?
Yes, ma'am.
Okay. So how will you assess? 6 points. Note down everyone. First point, may I know her vitals? If she has any other medical or surgical comorbidities. Third, may I know her abdominal examination pertaining to any uterine contraction? May I know her vaginal finding, that is her Bishop's score? How is her CTG? May I know more about her diabetes, whether it's type 1, type 2? Is it under control? What all medication she is on? And what is her current sugar report? Her scan about estimated fetal weight, AFI, and the placenta position or placental localization. Okay. Sugar is under control, Rekha. In that case, it is not going to be semi-urgent. Now, how will you differentiate between routine, semi-urgent, and urgent? Urgent is something, if you do not do anything, either you are going to lose baby or mother. Semi-urgent, you are not going to lose baby or mother, but definitely you need some kind of intervention to take this patient further. Routine, if you do not do anything, even in next 4-6 hours, nothing is going to happen to mother or baby. Am I clear about this?
Yes, ma'am. It's the routine case.
So now who is going to repeat? Who is going to repeat how to tag any room, routine, semi-urgent, and urgent?
Urgent means if there is any
Other than Rekha, because it's only Rekha who is responding. I do not like one-sided this session, because I find it very boring when only I am speaking or one other girl speaking. Rest all are sleeping.
Ma'am, urgent means that the patient and mother and baby condition is deteriorating, and in the routine that nothing will happen to the mother and baby even after without management for 4 to 6 hours.
This is
This
routine.
is the routine.
And what about
Yes.
semi-urgent?
Semi-urgent that some intervention is required for 4 to 6. Ma'am, I don't get the semi-urgent.
Acha, who will explain semi-urgent other than Rekha? Rekha is now going to be after me. If nobody is
Ma'am,
answering, then I'll pick Rekha.
ma'am, is it a pregnant lady? All pregnant ladies are coming under the semi-routine,
No.
semi-urgent?
In that case, labor ward prioritization, it is only semi-urgent and urgent. There is no routine. Because when it is labor ward, it is pregnancy.
Yes, ma'am. Ma'am, without any risk factor.
Semi-urgent
Pregnant lady without any risk factor.
No. This is not the criteria. No, this is not routine. Simple, you remember that way. Routine means if you do not do anything for next many hours, nothing is going to happen to mother or the baby. Simple. So if patient has come with controlled diabetes for induction, even if you don't do induction for 6 hours, Rekha, is it going to affect mother or baby?
No, ma'am.
Clear? Who asked this question? Fatima? Who asked this question?
Ma'am, which question? Semi-urgent? Ma'am, me, sir.
Okay, sir. So this is routine. What is semi-urgent? Semi-urgent, listen to me carefully. There is no direct harm to either mother or baby, but we need certain kind of intervention. Though if we do not do any intervention, it is not going to, like, mother is not going to die, baby is not going to die, but some harm can happen to mother or baby. So that is semi-urgent. Urgent, when if you don't do anything, you are either going to lose mother or baby, or you are going to have major comorbidity. If not mortality, at least morbidity. Am I clear about this? Urgent, if you do not do any action, you may have any mortality or morbidity or major morbidity. Then it is urgent because you have to do something now itself. Semi-urgent, It is not something which is going to cause any kind of mortality or major morbidity. But definitely, if you do not do any kind of intervention, some deterioration is there. Routine, if you don't know and don't do anything, it is not going to cause any problem, either mother to baby. So now I'll explain with this first room only. If diabetes is under control, it is going to be routine. But patient has come for induction of labor because her sugar is not coming under control, then it will become
Urgent.
Semi-urgent. Semi-urgent.
Semi-urgent. Semi-urgent.
right. So now you got my point, Kesar?
Yes, ma'am.
Okay. So
Thank
now
you, ma'am.
so in assessment, we are going to ask vitals, medical surgical comorbidities, abdominal examination pertaining to contraction, vaginal for bishops, her CTG, her current condition, like whether the DM1, DM2, if DM1, then what is the dose of insulin, whether sugar is under control, and if DM2, what is the medication, whether she is on diet control, and what is the sugar report, the latest sugar report. Then scan is very, very important for estimated fetal weight. Always say estimated fetal weight. This is SD. You have to use jargons. Estimated fetal weight, AFI, placental localization or placental position. Then you are going to recommend. It is a routine case for me. I'll send my midwife. She will apologize for delay and she'll go through her case notes on the basis of her Bishop score, and she'll offer her all the available options of induction of labor. Taking her concern in consideration, she will decide about the induction. Consent would be taken. Diabetologist would be informed. Consultant aortologist will be in the loop. Once she will be in the labor, we'll do the sugar charting. That will be on the basis of whether she is in anesthesia or not, right? And what should be the reading, right? But if it is DM1, then insulin dextrose drip may be needed, or may be needed what we needed, right? Clear?
Yes, ma'am. Yes, ma'am.
And once baby will be delivered, immediately we'll check for sugar, and in early breastfeeding would be encouraged. This much you have to speak in this room. Now, second room, who is going to attend? Who wants to?
Shall I do, ma'am?
Yeah.
Yes, ma'am.
Start with introduction.
Okay, ma'am. I am a doctor on duty in the labor room. I have received a handover from a colleague at 8:30 a.m. I have been allotted a team of colleagues with me. So I will allot them tasks according to their competencies, and I myself go to the urgent room, and I will prioritize the rooms into urgent, semi-urgent, and routine. And I will go room wise. So after the room number 1, I will go to the room number 2. Here there is a patient who has delivered half an hour back, and she's awaiting for suture. In the background, she is 26 years old, and she was a term. And I just want to know about her vitals, and whether she is
Pause,
bleeding.
pause. Until
Yes,
you
ma'am.
pause, examiner is not going to respond. Pause.
Okay, ma'am.
Vital, pause for 2-3
Okay.
seconds. If I want
Okay.
to reply, I would. If I don't want to reply, I will not look at you.
Okay, ma'am. So I just want to know about her vitals.
Vitals are fine.
Okay, and whether she is bleeding vaginally, any bleeding from the episiotomy site.
No.
Okay, so any other risk factors this patient is having? Any information about that?
No.
Okay, so this case is semi-urgent for me, so I will allot this task to one of my midwives, and also I will ask the midwife to apologize the patient for the delay.
Okay, that's it.
Yes, ma'am.
We will not talk about how you're going to manage episiotomy suturing.
Okay, ma'am, we have to tell that also.
Yes.
Okay, so I will I will tell my midwife to suture her in the labor room. with her verbal consent, in the presence of adequate lighting.
That's it.
Yes. Also, if it is a 3rd or 4th degree tear, after proper examination of the
Yeah,
patient.
it's not clear. It's episiotomy. It is.
So I just want to know, yes, she's not. Is it a
My
first?
midwife would examine properly, or my midwife would do a proper vaginal examination, whether is there any tear as well. Examiner will say, no, there is no tear, it's only episiotomy.
Okay, then
what-
I will ask my midwife to suture her in the labor room with her verbal consent, in the presence of adequate lighting.
Okay. Under aseptic
Under all aseptic precautions.
and proper suturing of episiotomy, followed by needle and swab count,
And
meticulous
external.
meticulous suturing, followed by needle and swab count, assuring hemostasis.
Okay. Okay, ma'am.
Hemostasis you have to assure, no?
Yes, ma'am.
And then encourage to pass urine. Once I would be free, I would be coming to this room, examining her episiotomy, reassuring her hemostasis, and then patient will be shifted to room. Unless you see patient, unless she has passed urine, unless you are assured about her hemostasis, you will not shift patient. Am I clear?
Yes, yes, ma'am. Thank you, ma'am.
So, okay. So how you are going to say this? Room number 2, ABC, awaiting for episiotomy suture. This is her situation. Awaiting for episiotomy suturing. In her background case, she had delivered half hour back. This is her background. Concern is what? We need to suture her episiotomy. This is our concern. Man was about to fall from mountain. That was our concern. In her background, she was walking. This was her background, no?
Yes, ma'am.
So our concern is ABC, room number 2, awaiting episiotomy suturing. In her background, she had delivered half hour back, and this was her first pregnancy, full term. Her age is 26. May I know her vitals? Any other medical surgical comorbidities? Abdominal examination in regards to or pertaining to how is her uterus, whether uterus has contracted or not, right? So
Yes,
abdominal examination in regards to uterus contracted, whether uterus is contracted, vaginal finding, if there is any bleeding, if there is any tear. Here you'll ask, if there is any bleed, this is vaginal finding assessment. If there is any tear, any active bleeding from episiotomy or any active bleeding. She might be bleeding because uterus is not contracted. Then CTG will remove hair. Scan finding will remove hair. So we have 5-6 points in assessment. Here you are not supposed to ask about CTG. Here you are not supposed to ask her scan. But definitely vitals, definitely abdominal examination, whether uterus is contracted, vaginal finding, whether is there any fresh bleeding or any active bleeding, not the fresh bleeding, we'll say active bleeding, it's SD. Is there any other tear? Right? Then after this assessment, you are going to recommend. If she is having active bleeding from episiotomy, then probably midwife is not the right option. Then you are going to say somebody senior. No?
Yes, ma'am.
Right? So here you will say that because there is no active bleeding, nothing. This is semi-urgent case for me. I'll send my midwife who can suture episiotomy because they have given two group of midwives, one who are able to suture and one who is able in putting cannula. So here we are going to send midwife who is able to do this suturing. Then it is a semi-urgent case. So first, she will apologize for delay. Second, she will do a proper vaginal examination to reconfirm if there is any tear, any bleeding. Then she will be doing meticulous suturing of episiotomy under aseptic precaution, under adequate lighting. After that, needle confirming needle and the swab count, ensuring hemostasis, encouraging her for urine. This will be done in labor ward itself with her verbal consent. Once I'll be free, I'll be coming to this room, reassuring hemostasis. If she has passed urine, then we'll shift her to her room. Nowadays, we do not wait for episiotomy suturing. Earlier, we used to wait, but now the current protocol says if there is episiotomy, we have to suture it immediately. Even if it is like not the third degree perinatal, if it is a second degree or even first degree perinatal, we have to suture it then and there, even if there is no active bleeding. If active bleeding, then it will become urgent case. In that case, probably vitals will also be deteriorated. If there is no active bleeding, it is episiotomy, then it is semi-urgent. Clear, everyone?
Yes, ma'am. Thank you, ma'am.
Anybody
ma'am.
want to add something in this?
No, ma'am.
Okay. So now who wants to try room number 3?
Ma'am, me,
Who's this?
Ruma.
Okay, Ruma. So this is...
Ma'am, one doubt, ma'am, in the previous case. If it
Sorry?
is an urgent, one doubt, ma'am, in the previous case, room number 2. Ma'am, if it is urgent, then we have to prioritize the case, assign the task to consultant, ma'am.
No. Even if it is active bleeding from episiotomy, I think even ST4 can do that, no?
Okay.
But if bleeding from the episiotomy, then any senior ST can handle this. If even you don't need, even ST5 is also not needed. Do you have that a chart where they have given the list what ST4 can do, what ST3 can perform? Do you have that chart? Anybody? Okay, I'll post that chart in free group where they have given clearly who is authorized for episiotomy, who is authorized for perineal tear, who is authorized for simple cesarean, who is authorized for complex cesarean, right? I'll send that chart in the free group. Okay? Okay.
Okay, ma'am. Okay.
Yeah, now room number 3, who wants to present?
Yes, ma'am. The patient is 39 years old, HIA. She has 1000 ml blood loss after delivery, and she's in ICU. Her background is that she was 38 weeks pregnant and she had assisted vaginal delivery, and she delivered 4 hours back, and she delivered 4 hours back. I want to ask about her vitals and about any medical and surgical comorbidities, and about any abdominal examination, and about abdominal examination.
Okay.
And about vaginal examination.
No information. Now move further.
So according to me, according to me, the management should be that I will first of all I will call for help, and I will immediately resuscitate the patient. I will call anesthetic also for my help, and I will maintain 2 IV lines, and I will push crystalloid to the patient.
Ma,
And
Roma, she had delivered. She had this blood loss. Now she is in
SDU.
So when you will shift in SDU, whether are you going to do all the maneuver in SDU or on a OT?
I will first of all I will shift the patient.
She is in SDU, right? So probably
Yes.
she is already, because she has not delivered now. She had blood loss after delivery. Now she is in SDU.
Recording in progress. And display your talent as well, just as
Somebody is doing 2
Hello.
timings. Who is this?
Hello.
Actually, this is also like an acting. So
Okay. Yeah.
Yes, ma'am. So, ma'am, she's in SDU, so I will assess the patient, and I will recommend vitals monitoring for the patient, and any need for blood transfusion, and if her condition deteriorates if her condition deteriorates, then I will assess the patient. I don't know.
Okay. 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 It was good, Ruma, but definitely there is a scope of improvement. Anybody else who wants to present this?
Ma'am, shall I try, ma'am?
Ma'am, may I?
Who's this? Please mention name. Because I'm not
Rekha.
able to see. Sorry?
Rekha.
Rekha. Yeah, Rekha. Anybody else?
Me also, ma'am.
Ma'am,
I
shall
can
I
also
do,
present.
ma'am?
Okay, we'll
Yoga Priya.
give me your name, please.
Yoga
Fatima.
Priya, ma'am.
Yogpriya and third.
Fatima.
So first Rekha is going to present, then Yogpriya, then Fatima.
Okay, ma'am.
Rekha, shoot. Shoot, Rekha.
Okay, ma'am. HIA in room number 3 with a primary PPH. She delivered 4 hours back. She's 38 weeks, para 3, live birth 3. So here I would like to know about her current observation and what has been done in the last 4 hours.
Her vitals are fine. I have not much idea what all has been done, but now bleeding is under control.
Okay, so her uterus is contracted, and what is the current amount of the bleeding?
What is my information is that patient is now under control. That's it. That's the information I have.
Okay, so it means that her condition is controlled. So we will, it's a semi-urgent case. I will send my anesthetic registrar along with my ST1. She will going to observe her and make sure that the patient is hemodynamically stable. And also NTD will be given to the patient. And we will check her post-operative complete blood count and also if it is to see if there is any need of blood transfusion. And we make sure that her oxytocin infusion is running on.
Okay, what if she has this PPH because of some cervical laceration? In that case, would you be needing oxytocin?
No, if there is any lacerations, if the cause is not atony, then we have to, of course, stitch the tears.
Okay. 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 It was good, but I'm sorry, Rekha, it was not best. But it was
okay, ma'am. Fine.
Yogpriya?
Ma'am, in this case, like in a post-operative recovery room, I will, ma'am, you asked me for this case only, no, ma'am?
Yes.
In post-operative, I mean, HDU unit. So I would like to add few points like if she has cervical laceration, whether she is on antibiotics and whether she getting adequate pain relief. And then and I'll ask my ST1 to check the observations frequently, like every 4th hourly. And then I will check the urine output also, whether it is adequate and proper fluid management being done or not. Then I will raise the incident reporting. I will debrief to the patient and also the relatives.
Lovely.
And yes, I will document
this kind of
everything.
situation come, Yogpriya and Rekha, always divide your recommendation in 2 parts, clinical management and clinical
Risk management.
governance.
About it.
Clear? Clinical
Yes.
management and clinical governance. So you will manage recommendation. Okay. And now
Yes,
Fatima.
Yes,
Love
ma'am.
you, Priya.
Yeah. So in room number 3, patient is HIA, 39 years old. I have a situation. She's in the high dependency unit after management of the primary PPH. In the background of sister vaginal delivery that was done 4 hours back. And patient is RH negative. She's para 3 with 3 live issues. She delivered at 38 weeks of gestation. For this patient, I need to know further information regarding her current vitals. Her uterus is contracted or not, amount of the vaginal bleeding, and what was the cause of the PPH. And I want to inquire about the baby. Either the baby blood group has been tested or not.
Lovely.
And
Lovely.
NTD has been given or not.
On the basis of baby's blood group. Rekha, here you compromise patient safety.
No, ma'am, I give in NTD.
No. Will you give NTD to everyone?
No, baby blood group is negative, then we don't need to.
You have to check
Baby's blood.
Yes. This is how we miss some
Hmm.
patient safety. Lovely,
Okay,
Fatma.
ma'am.
This is what I wanted to hear. Lovely.
Thank you, ma'am.
Yeah. And
So, so regarding the recommendation, so I will send this will be semi-urgent case. So I will send my ST1 and for the further monitoring of this patient regarding her vitals, uterine contraction and amount of the bleeding, intake output record, and intake output record, and will encourage the patient, the breastfeeding nurse will be involved to encourage the patient for the breastfeeding if mother and baby are like okay. And then ma'am, once patient I will finish the labor ward, I will go to the patient, I will assess her by myself, and I will do the debriefing regarding
lovely.
her case.
Lovely.
Incidence reporting is, madam, no necessary because she's having 1000 ml. It's more than 1500
Now,
ml.
what is the other criteria of Detics form?
Uh,
Other than blood loss?
Other than ma'am, if she went for the operation theater, like
And if we need
Assisted
to
Hysterectomy
vaginal.
was done due to this.
sorry,
Hysterectomy.
and
Death.
and
embolism, ma'am.
Cervical tear.
and
Ma'am,
Embolism.
third or fourth degree peritoneal tear, ma'am.
and
If
Assisted vaginal delivery, ma'am.
and
ma'am, if she got unfortunate complication like the pulmonary embolism or amniotic fluid embolism.
and what is the criteria of Detics form here?
1500 ml blood loss,
Blood
ma'am.
loss
More
is
than
1000 ml.
Sorry?
Ma'am, it is
blood
normal
loss
vaginal.
is more.
It is vaginal delivery and blood loss is 1000 ml. Ma'am, 1500 ml is in case of cesarean section.
And
Forceps delivery, ma'am, if complication arises because of course.
and I keep asking, and I think you gave me correct answer.
She is
Cervical
in high
tear.
dependency unit, ma'am.
Who is this?
Sorry, Fatima. No,
Who is this?
me, ma'am, Fatima.
Perfect.
Ma'am, I told this point before.
HDO, it's
So
the
I'm
Detics
sorry, I probably couldn't hear you because so much voices together. When patient needs to transfer to intensive care admission,
Yes, ma'am.
isn't it a cause of Detics form? A reason for Detics form?
Ma'am, I'm not sure about that. She is in high dependency unit. If for every patient we shift in the high dependency unit, we fill the Detics form. I'm not sure.
That is intensive care, no? High dependency is intensive care. We do not shift every. Do you shift every post-delivery patient to SDU?
No, ma'am.
No,
Only
no, if the
complicated
complication arises, then.
complications happen.
Yes,
then.
yes.
But ma'am, because of the complication, we are shifting the patient to the. But in the.
We always shift patient because of complication, no, Rekha? Why we shift any
But here,
patient to
ma'am.
intensive care? When there is any complication and patient needs close monitoring. Myo charting. Nobody mentioned myo charting.
Yes, ma'am. Yes, ma'am. Enhanced recovery program and myo charting both.
Room number 3, HIA, primary postpartum hemorrhage in SDU. This is the situation. What is the situation currently? Patient in SDU in view of primary postpartum hemorrhage. This is situation. Room number 3, HIA. In view of primary, I like this, Rekha, you said this primary postpartum hemorrhage. You mentioned this, right?
Yes, ma'am.
This is the diagnosis. You are talking to consultant. You have to give diagnosis. You should be intelligent enough to make diagnosis. Normally, when you were doing your PG, your consultant used to come for rounds. Don't you give diagnosis to them?
Yes, ma'am.
When you are registrar in 3rd year, you will do that, no? Room number
Yes,
3,
ma'am.
HIA, in SDU in view of. Why we have shifted her in SDU? Primary postpartum hemorrhage. So in view of primary postpartum hemorrhage, in her background, she delivered 4 hours back and had a blood loss of 1000 ml. This was her third delivery and she was in her 38 weeks. May I know her vitals, whether it's stable? May I know her if she has any other medical or surgical comorbidity? What if she has any blood disorder? It is so very common in UK. May I know her abdominal examination, whether uterus is contracted? Who asked this question? Yogpriya, you or Fatima?
Me, ma'am. Me, ma'am.
Ma'am, me also.
Very good. Then in vaginal examination, whether is there still active bleeding? What is the cause of primary postpartum hemorrhage?
Yes, ma'am.
Then after that, you are going to recommend her that if she is like vitals are stable, uterus is contracted, no active bleeding, then it is a semi-urgent case and make a rule when patient is in intensive care, anesthetist has to be there. Anesthetist is the in charge of any intensive care unit, right?
Yes, ma'am.
And here, why you want to go when patient is stable? You send your midwife. Why you want to waste your manpower? You will send your anesthetist and midwife. It is a semi-urgent case for me. Anesthetist would go. Never say, I would ask my anesthetist to do that. This is a kind of bullying and demeaning your colleague or junior. Clear?
Yes,
Never,
ma'am.
I will ask. My anesthetist will check her Mio charting. Will go through her drug chart, whether antibiotic and other treatment has been started. Patient needed any kind of blood transfusion during this process. About her investigation, like full blood count, coagulation profile, liver function, kidney function test, will check the report. And midwife would check her uterus, whether it is contracted, and will do a local examination of vulva and vagina if there is any active bleeding, and if is there any episiotomy or perineal tear repair, and so what is the status of hemostasis. If patient is catheterized, then input output charting. Then Datix form, never say incident report, it is SD, say Datix form filling. Documentation of events, debriefing to patient, birth companion and the team. DVT assessment, blood loss, don't you do DVT assessment? Right?
Yes, ma'am.
And risk management, auditing if repeatedly cases of postpartum hemorrhage. Here you complete your room. Who wants to repeat quickly? One volunteer. I don't want you to miss, and you'll talk about NTD. NTD after confirming baby's blood group. If it is negative or positive. If you want to mention that, you can mention that. That if it is negative, then it's not required. To repeat this fast, 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 fast.
Ma'am, should I try?
Yeah.
Okay. So, room number 3, patient is HIA, 39 years old. She's having she's a case of primary postpartum hemorrhage, and after management, she is in the high dependency unit in the background of assisted vaginal delivery 4 hours back. She's having negative blood group, and she's para 3 with 3 live issues and delivered at 38 weeks of gestation. For this patient, I need to know further information regarding her vitals. And the uterus is contracted not currently, how much she is bleeding, and what was the cause of the PPA, and what is the blood group of the baby.
Okay, go ahead.
And so for this will be my semi-urgent case. I will send my midwife for the assessment of this patient, and the Caesar registrar will be there to see the patient. So for this patient, she will be monitored in high dependency unit on a new chart regarding her vitals, intake output record, uterine infection, and breathing per vaginum, intake output record. My midwife will assess the investigation, including full blood count, renal function test, liver function test,
No.
coagulation.
Anesthetist would do that. Midwife won't
Okay.
check blood investigation. It is anesthetist job when he's there.
Okay, so anesthetist registrar will check her investigation, including full blood count, liver function test, renal function test, serum electrolytes, and coagulation profile. And if need will arise, the blood will be arranged and transfused.
Simply say, make it shorter. If any need of blood transfusion. Simple.
If any need of the blood transfusion. Okay, so depending on the blood group of the baby, midwife will check either she need NTD or not, and if she needs, then the NTD will be given according to the unit protocols, and her VT risk assessment will be done, and she will be managed by enhanced recovery program with the VT thromboprophylaxis, including early mobilization, compression stockings, and low molecular weight heparin will be given if need arise. And ma'am, and once patient will be stabilized.
Debriefing, documentation.
Yeah, once patient will be stabilized, the debriefing will be done with me and along with my team to the patient and the family.
Documentation of all events in chronological
documentation
order.
of all events will be done. That is form will be filled, and if this will be a repeated incident, then the risk management team will also be involved.
Okay, so Rekha, are you clear about this?
Yes,
Rekha,
ma'am.
Yopriya?
Yes, ma'am.
Okay. So now who wants to present room number 4? This is the easiest one.
Can I do?
Yeah, sure.
I will do.
Someone is not volunteering. Hello, ma'am.
Yeah.
Someone is doing or not?
Yeah, you do.
Yeah.
Okay, thank you, ma'am. My next patient is in room number 4, Zia, 28 years old. She's here for the she's here for the induction, in the background of induction of labor. She's primary gravid at 40 weeks. So for this patient, I need to know what are the vitals of the patient, her abdominal examination, her Bishop score, her recent ultrasound regarding the estimated fetal weight, amniotic fluid index, placental localization, and what is the ma'am इसमें पूछना चाहिए what is the cause of induction of labor?
She's 40 weeks probably, that's fine. Low risk, they are already mentioning.
Okay, and what is the current CTG for this patient?
You forgot medical and surgical comorbidities, though it's given low risk, but still at least you can ask for surgical one.
Okay, if any surgical or medical comorbidity she is having, I need to know patient blood group as well, and if any allergies she is having.
The blood group and allergies we are going to talk in the beginning when we give the this introduction. That I'll quickly go through the patient's case notes to rule out if there is any risk factor like drug allergies, blood group, Jehovah's Witness, medical surgical comorbidities, any high risk factor for DVT, and smoking. This you will say in the introduction itself.
Okay.
Then
so yeah, so for this patient, this is a low risk patient, so I will send my midwife to apologize the patient and check her
prioritize and delegate.
this will be routine case, ma'am. Routine case. I will send my midwife as this is
Otherwise you will miss. If you'll miss mentioning prioritization, you will lose marks. So make a habit of prioritizing and delegate together.
Okay, so this will be my routine case. I will send my midwife for her record assessment, for assessing of the Bishop. She will do the CTG, and all the options of induction of labor will be discussed with the patient, and according to her wishes, the informed written consent will be taken. And after settling of the labor room, her induction will be started, and my consultant will be informed regarding this patient.
Okay, perfect. Okay. So now who wants to speak? Now room number 5, who wants to present this?
Ma'am, may I do?
Yeah, do. Come on.
SIA with APH. She's 32 weeks, gravida to para 1, and no one has seen her. So I would like to know about her observation, any medical and the surgical comorbids, any what about her CTG, contractions, and the amount of the bleeding.
Okay. No information because no one has attended her so far.
Okay, so here I would like to review her records with her permission and do the examination in the presence of the chaperone with her consent, checking her contractions, and do the CTG to see the fetal heart sound, and also the contour of the uterus to rule out the abruption, and do the I also check the ultrasound to rule out the placenta previa, and do the if there is no previa, I will do the speculum examination to rule out any local cause, and also to see the how much she is dilated and amount of the bleeding. So, ma'am, I will manage by myself. There is no information available.
No, in that case, when there is no information, so when nobody has seen it, so it's not necessary that you will rush, right? Because you are SP5, you have other works to do. You might be having some top urgent cases. So you will send here first the midwife who can put IV cannula with the serial most ST you have. Because in such cases, you probably need to put cannula and you have to send certain investigation. So here, because you
So I
don't
will
have
say, ma'am, two conditions. If the patient is hemodynamically stable, then I will say it will be my semi-urgent case. I will send my midwife and she will make sure her IV line is maintained. And also we need to inform the consultant and the neonatologist. We make sure the cot is available. We will give the steroid cover and also the tocolytics for the steroid cover. But if in a case the patient is hemodynamically unstable, then it will be the top urgent case. I will go myself informing my consultant, and also then I will start with the protocol of the obstetric hemorrhage. MTT will be involved, including the consultant, anesthetics, theater team will be informed, specialist nurse, neonatologist, and we will make sure that her IV line is maintained. Blood will be sent for the complete blood count, renal function test, liver function test, coagulation profile, and the cross matching of the blood will be done, and fluids will be given till the blood arrive, and we will take the consent for the emergency cesarean section after informing the consultant and her relatives.
Okay. Okay. So probably, yeah, you have done a good job, no doubt about that, Rekha, because this station normally gives so much of dicey. These kind of stations are very dicey, right? To take it urgent or semi-urgent, especially if your examiner is not providing you any information.
Any information.
One more thing, that it's not necessarily that every time examiner is going to provide you information. There is a possibility that one of the examiner is not going to give you any information, because this is what the feedback I have it has been given by my student, that one student for the same exam saying that my examiner was not saying anything. The other, with the same day, other student is saying no, the examiner was giving all the information. So
Ma'am,
probably
the examiner, they are giving the information, but they are not allowing us for the introduction. They are saying directly talk about the
that case you
exam.
go that way. In that case, you go that way. Do not get fumble with that. Oh my God, they have asked me. Because this is again a examiner's own point of view.
Views, yeah.
Do not get nervous with that. Oh my God, I have done some mistake. No, you have not done any mistake. It's fine. If he's saying that do not do these things, then go ahead. In that case, make sure that blood group you are going to mention in any case where there is need of blood transfusion. The only awareness.
Ma'am, what happened? Sorry to interrupt you. What happened in my case? I appeared in the UK. So what was happening? I was asking she interrupted me. Okay, no need for the introduction. So I just started with the cases.
Yeah, it's
and
fine.
when I was asking the information, ma'am, and she was staring at me. And when I was thinking, okay, there is no information. And then I started case. Then she like talked. Then she was giving me information. Like she was giving me information after every 20 to, you can say, even 25 seconds. So
again, Fatima, you have to be ready. See, even when you are doing PG, you should be I'm sure that you must be remembering some consultants are like those consultants were so difficult, and some consultants were very cooperative, right?
Yes, ma'am. Yes,
Maybe
ma'am.
you are going to have examiner. This is also an exam, no?
Yes.
So every examiner won't behave same way. Every examiner will be having his own approach. So it's fine. This is the presence of mind you need. that you should not get humble, you should not get shattered, you should not get scared. Oh my God, what has happened to me? This is not happening to you alone, because that examiner is going to treat everyone same way.
Okay, ma'am.
It's fine.
Yes.
So that's why you need presence of mind, no? How to
Yes.
module the things, how to change the things, how to immediately change your attitude, your presentation on the basis of requirement, right? If you're cooking for 2 person and suddenly 2 other guests came, what would you do?
I will
Without
put
any,
more water.
will you, okay, raise your hand, so I can't do anything. Oh my God, I was just preparing for 2 guests. Or you will start preparing for 4 guests. What will you do?
Ma'am, we will start preparing for more. Like,
That's it.
definitely.
So you have 2 options. Either say, hi, what has happened? Or either smartly start preparing for 4. That's all.
Yes, ma'am.
Simple. Why you make your life so difficult? Don't make it so difficult. It is really not that difficult. The only thing you need, presence of mind. That's it. Clear? So if unfortunately, if your examiner is difficult, let it be that way. And what is my personal experience? Difficult examiner always gives better mark. They always give you better marks than the simple examiner. Because who
Yes.
is very tough, they are normally, after cracking the nut, that's very soft inside. Probably they are harsh in presentation, probably they'll give you better marks.
Ma'am, how many marks like one station have? 12 or 10?
Again, it depends. Again, it depends. It's not necessary. I'll send you that as well. Where they
Okay.
get complete, blueprint of the how they give you marks and what is how much SD, how much marks is allotted for SD, SPT, and teaching. I'll send that chart as well. But again, that is not your concern. Frankly speaking, Fatima.
Yes, ma'am.
That's not your concern. Your concern is passing and giving your best in every task. So now coming to this room number 5, which is a dicey station. So this is the introduction and assessment. All were fine. I'll directly jump to recommendation. You start with semi-urgent. When you don't have any information, Rekha,
Yes.
it is not going to be a routine case for sure. Either semi-urgent or
Yeah, the
we start
semi-urgent version.
we start with semi-urgent. This is semi-urgent. I will send midwife who can put IV cannula, and I'll send my senior most ST. Whoever is available, you just keep in your mind. If you have ST4, ST3. If you have ST3 is the senior most, then you send ST3. If you have ST4 senior most, then you'll send ST4. Okay. Then you will start. This is semi-urgent. I'll send this IV. My midwife would put the IV cannula and will send the investigation. This bedside ultrasound would be recommended immediately. I will inform my consultant neonatologist and will check the availability of cot, right? Steroid would be given with tocolytics.
Ma'am, magnesium sulfate can be considered if she is more than 4 centimeter or imminent delivery is there. Like, if it can be abruption. So we should say this.
What will I didn't get you? Can you repeat?
Me say if this is a case of abruption. So, and she is more than 4 centimeter.
If it is a case of abruptio, if it is a case of abruptio, patient's vitals are compromised, CTG is compromised, still you will offer her steroid, though probably not the tocolytics, but definitely you will give this steroid. What
Ma'am,
sure?
magnesium sulfate. I'm asking for magnesium sulfate.
Magnesium sulfate. What is the criteria of magnesium sulfate?
Ma'am, it should be given up till 29 plus 6 weeks, but can be considered up to 31
Consider.
plus 6
What
weeks.
will you say?
Consider. Consider.
Same with after 34 weeks, if somebody is coming with preterm labor, because now steroid we offer only after till 34 weeks. So you will say, we will consider.
Consider. Yes, ma'am.
Same way. Okay. On the basis of vitals, on the basis of amount of bleeding, we'll decide further action. If vitals are unstable, she is bleeding continuously, baby is deteriorating, we may plan to deliver her ASAP.
Early, yes.
But if bleeding is not much, then we keep her for the observation. Continuous monitoring of the vitals, input-output charting, urine output charting. If her vitals are under control, if the bleeding is stopped, if CTG is normal, definitely we're not going to deliver her. In abdominal examination, you will specifically ask during her assessment, May I know her abdominal examination, whether uterus is tender, continuously contracted? We want to rule out abruptio.
Yeah.
Say,
Stony heart.
say it specifically. Because, see, whether they answer you or not, it doesn't matter. They basically want to know whether you are aware of the fact that what all points you need to check. Right? So a patient who is coming with APH, what all you are supposed to check? A patient, whether you want to ask if there is any other episode or any previous episode of
Hemorrhage.
same condition, if there is any previous episode of APH.
Yes.
Right? Uterine, you will ask to know about abdominal examination, whether it's tender uterus, whether it's contracted, whether patient is having any contractions. Because there is a possibility patient might be going into labor. Then a recent or latest ultrasound, definitely you are going to offer her ultrasound then and there, but latest ultrasound whenever it has been done, what is the position of placenta, whether it's a case of placenta previa. So if any scan be, because you come to know about placenta previa at 20 weeks, then they do the scan at 32 weeks, right?
Yes, ma'am.
What can be the causes of APH?
Ma'am, it can be placental causes, it can be localized causes, and in the placental cause, it can be placenta previa, placental abruption, and other placental abnormalities. And it can be the local causes like cervical or
Hypertension.
laceration, vaginal varicose, and it can be the medical, like if patient is taking any anticoagulation.
Yes. What
Can be a domestic violence.
what is patient of low molecular weight heparin? There could be multiple reasons, no?
Yeah. So domestic trauma and hypertension, they are causes of abruption most likely.
Yes, you will rule out. You have to say this thing.
Yes.
You have to say all these points in your assessment. That is there any other episode of APH will rule out domestic violence. If you say these things, see, if you justify that your case is semi-urgent, but you can justify this, you will pass the room. If you say urgent and you can justify this, you will pass the room. Right? Obviously, you will not tag it as a routine. Just a minute, I have a call from hospital. Just give me a sec. Okay, so I repeat assessment because in this case, assessment is very important. Situation you understood, that CR, APH and background you understand. So how you'll start assessment? You'll ask about the vitals, whether patient is hemodynamically stable, or if patient, or one more tip. If your examiner, Fatima, if your examiner is not giving you any hint, then how will you start? First, in assessment, we always ask about vitals, right, Fatima?
Yes, ma'am. Yes, ma'am.
So you'll say, may I know the vitals? Patient is staring at you, sorry, examiner, and not responding. Now simply make it more simple. If hemodynamically stable, then it will be a semi-urgent. If unstable, then it will become urgent. Because then you have to slightly change your presentation. Second, may I know the amount of blood loss? May I know any medical comorbidities? Abdominal examination like uterine size as per week, if any contraction, tender or tense to rule out abruptio. If in that case, it is an urgent case. Vaginal, no digital examination, only speculum examination. May I know the CTG? Any recent scan to know the condition of placenta, localization of placenta, or rule out placenta previa. If there is any history of same complaint in previously, any trauma, we will rule out trauma as well, no?
Yes, ma'am. Yes.
Rule out any domestic violence and any PPROM. So in prioritization, semi-urgent or urgent. According to, if they are not responding, then you say this way. Advice. Admission under MDT. Inform consultant. Bedside scan. Because further management would be on the basis of either placenta previa, abruptio, any other reason.
Local.
IV access by midwife, sending full blood count, blood group, save, cross match. If blood loss mentioned, then as per amount, we are going to follow the what is our protocol which we have, that we send this, then we stabilize, then we send investigation, etc. If need to deliver, then steroid, neonatologist, cot, availability, anesthetist, OT team, debriefing, patient, birth companion, documentation, duty of condor, if it is required. Duty of condor, definitely you are going to say, because you are going to deliver before time. In and incident reporting on the basis of blood loss post delivery. Clear? So basically, assessment may do ask about amount of blood loss. Vitals, say clearly. If they are not mentioning anything, then say whether hemodynamically stable, unstable. If stable, then semi-urgent. Unstable, then urgent. Abdominal examination do mention about uterus, whether it's corresponding to weeks, and if there is any contraction, if there is a tender, tense abruptio, tense uterus, then it can be abruptio. Then vaginal examination, CTG, recent scan, and then any history of same complaint, and then trauma, then domestic violence, PPROM, then prioritization, and then recommendation. Definitely, the first recommendation would be, in such cases, you are definitely going to admit her. 32 weeks APH, whatever amount, at least she will be needing admission for observation. So that is patient safety. Admission under MDT, bedside scan immediately. Previous scan review. Previous scan review, IV access, sending all the investigation. If need to deliver, then steroid neonatologist caught. Even if she's having like, if you don't want to deliver now, but she is having a significant amount of blood loss, you will offer her steroid. And then the magnesium sulfate, you may say consider, but definitely you're not going to offer. Debriefing, documentation. These are very important points.
Yes, ma'am.
This,
Thank
I
you,
understand,
PUUJA.
this is a little bit a dicey kind of situation, this particular task, APH, but this is very favorite for college. They do give now and then, every now and then. So important points: not leaving any domestic violence, any trauma. In abdominal examination, do ask about whether there is uterine contraction or continuously contracted, or you can say tender, tense uterus, to rule out abruptio. Amount of blood loss, you will definitely ask. Bedside scan is very important patient safety. Admission is very important patient safety. And reviewing her previous scan for placental localization, again, very important. And cot confirmation if you need to deliver her, very important. Steroid, very important. Clear? Clear?
Yes, Dr. PUUJA. Yes, Dr.
Yes,
PUUJA.
ma'am.
So this is all for labor ward prioritization. Trust me on that. Labor ward prioritization is the easiest task. Easiest task, because everything is given on like in front of you, and everybody is aware of how you treat episiotomy, how you handle RH negative, how you handle IOL, how you handle APH, and how you manage this diabetes and suturing. Everything is like on your tips. Only thing you should understand how to present. Unless you know the assessment, you won't be able to recommend, because if vitals are stable, it is not semi-urgent. If the bleeding is around 30-40 ml, it is not urgent, right? If CTG is fine, if there is no vasa previa, what if the patient is with vasa previa? What if you come to know that in previous scan it is vasa previa? Then what you are going to do?
Urgent,
Huh?
ma'am. Where's the premium?
Urgent.
Urgent, ma'am.
Urgent.
Urgent.
Need delivery.
Urgent.
Category
Need
1
delivery.
cesarean section.
Cesarean section, ma'am.
Fresh
Have to
cesarean
inform the
section.
OT team
Category
and
1 cesarean section.
Section. Availability of blood bank, blood transfusion, hematologist.
Cot. Cot
Neonatologist,
in NICU.
cot, incident reporting.
Yeah. So now you all are expert. Okay. So just
Thank you so much, ma'am.
Always welcome, darlings. I just brief about my courses. So AMMR COG 16 weeks. My last batch of AMMRCOG 16 weeks for 24 May. I'm going to start from 28th December. This is going to be my third batch of 16 weeks where I keep only 2 or 3 students at the max. So this is daily practice. 180 recalls we are going to cover. No compromise with your life and family because you are going to present one task a day for first 1 or 2 months. Then we are going to shift 2 or 3 tasks. So it is very easy going kind of course. And just a minute. Answer keys will be provided for all 180 recalls, either audio or video. A very organized study material. I do not believe in chaotic library just to show that I have a huge library that you will just wondering in library only where I have to read, what should I read. No, I don't believe in that library because that exhausts, that consumes so much of time. So very precise answer keys with for all the recalls, one by one, DM this everything, and either in audio or we this written study material. Very precise study material. I do not provide RCOG, I do not provide nice guidelines because I'm sure you all are having this study material. You are going to get very precise material for SD or SPD in form of written information leaflet, PIL. Voice library, again, it is not like a random voice library. Only I have library of my star performer who have scored like 80%, 89%. So their presentation for almost all recalls, like, so it is hardly 3 4 students I have kept in this library. So you can hear only cream presentation. So this is my 16 weeks course going to start on 28th. And in the end of the course, every student is going to present every recall and going to get detailed personalized feedback, right? And in the end of the course, there is one mock is with this of 7 station, right? One to one live session, which where you are going to present 7 station, and that is again going to one. It's like you and me. That's it. This is AMMRCOG. After that, unique. This is one-to-one live session course. This one is Telegram, and this is a live session Zoom. 10 live session, 50 recalls. Overall, I'm going to cover. That can be of your choice. And in each session, we are going to do 5 station, 5 tasks or 5 recalls in one session. Overall, 10 live session. Again, we'll decide about the time as per your and my convenience both. And you will be provided with study material channel. And again, the same wise library I was talking about. And third is the labor ward prioritization. This is my most best seller, you can say that. And I personally like this group a lot because my answer keys are absolutely incredible in this. I really like, because I took too much of time to make the answer keys for labor ward. Again, you do the daily practice and approximately we cover 80 rooms with labor ward prioritization, gynae ward prioritization, and post gynae cases as well, which is a new love of college, right? And I cover more than 80 rooms approximately.
Ma'am, can you send the fee or everything, and one we can join or like everything?
Okay, so I'll send it on free group. Is it fine for you?
Yes, ma'am. Yes, ma'am. I'll check.
And AMMRCOG 10 weeks, I'm going to start from 21st June and we are going to finish not in 10 weeks exactly. I'm just extending it for 10 to 12 weeks. And again, daily practice, but here we do at least 3 recalls every day. Otherwise, it is going to be exactly like 16 weeks course where 180 recalls, everybody is going to present every recall and everybody is going to get detailed feedback. And I'm very critical and very strict. At times the student doesn't like my way of feedback, they find it very rude, but I always prefer, if I'm rude here, probably you will be able to face your exam more in a very relaxed manner because you have gone through lots of scrutiny under me. Then same answer keys, which are very good study material, and the voice library. The only difference between 10 weeks and 16 weeks, the same course we finish in 16 weeks, there we finish in 10 weeks. Otherwise, it's absolutely same. Other than
Dr. PUUJA, one please. In these recalls, the November recalls will be included.
Everything. November recalls till last day. Even in labor ward prioritization, whatever new room has come,
my labor ward was shit, ma'am. There was no top urgent. I don't know. I didn't heard from any student who appeared in the UP and pass. I don't know what is that in this November
In
attempt.
labor ward you cannot pass.
I
Who,
don't know, ma'am.
who
Yeah,
said you?
I was on a seventh station.
No,
The
no.
bell rang.
Again, they make so much of how this, labor ward prioritization. And if you take my opinion, I think this is the easiest task.
I
First,
was thinking about, and I present to you, ma'am. Definitely, you note my weaknesses and strength as well. The thing is that when I was reading outside the cubicle, it was not too much difficult. That I was thinking I can make it, but when I
see,
go inside, I totally confused.
Is it Fatima, right?
Yes, ma'am.
Fatima, why everybody finds labor word prioritization so difficult? First, because they do not have that format. If you are aware that you have to go with S bar, there is no reason that you won't be able to present your room nicely. There is no reason. Secondly, why they find it difficult? Because they do not know how much they need to speak in recommendation. So
You are right. In one room, I was spending too much time. I realized.
I'm telling you why. Amna, I do not have any active listener kind of thing because I do not believe that in MRCOG part 3, I do not believe that any listener is going to get any help. I told in the beginning, part 3 is about speaking, not listening. And in my 10 weeks course, it is a Telegram course, Amna. It is a Telegram course where where I put my tasks daily, at least 3 tasks if you go for 10 weeks, and you have to present all 3 tasks in 24 hours. And then you are going to get feedback on that. And in the end of the this course, that is once you complete your 10 weeks and complete your course, then there is going to be one live session, you and me, and 7 station for that. Okay.
Ma'am, we have to record and then we will send on the Telegram.
Yes. So normally I keep 2 or 3 students. So I just want you to mingle with each other so you can play role player to each other. Because you have same study material, you have same voice library, you have same answer key, and you have same task. So if say you are there and some friend is your there, so you can play role player for her and she can play role player for you, and then you can send me recording. Then you are going to get detailed feedback. My feedback is, trust me on that, it is not 2-3 minutes feedback. It takes good 15-20 minutes. Sometime I want or I may ask you to rerun that, represent your task if I'm not happy at all with your presentation. I may sound quite strict taskmaster. Most of my students say that I'm very strict, but I think that that is the only thing which can keep you on track. Right? Hello? Hello? Can you hear me?
Yes, ma'am.
Okay. So, you were saying something. I interrupted you, Fatima. I'm so sorry. Fatima? No, Manoj. My live session course is unique course. Live session course is unique course where 10 live session, and this is only 1-to-1. Means only me and one student. It is not that me and 7 students. It's only you and me. 10 live session. In each live session, you only present 5 recalls or 5 station. You will present 5 station in one live session, then second live session, third live session. So 10 live session, 50 recalls only you are going to present. It is 1-to-1. It is not a group live session. Okay. Any other query? And 16 weeks course, this is a Telegram course. The same way, every day I'm going to put a task. You will be getting answer key, a proper answer key for every recall, voice library, study material. Every day you're going to present me one recording, one task, getting feedback. After 1.5 months, when you will pick up some pace, then it is going to be 2 tasks or 3 tasks close to exam, because we are going to finish this somewhere on 20th April. Then it is going to be 3-4 tasks in a day. And in the middle of the course, I give another schedule for revision. In the middle of the course, somewhere in February mid, I'm going to give you another schedule where you are going to start your revision. Okay? Any query about course, everyone can DM me. Sunita, you want to be added? So what you can do, if you can say hi in my Telegram group, so I'll add you. Okay? Okay, Sunita? Okay, done. Very well done. You all, thanks for joining me. And I always like good participation. Most of you were participating quite actively. Try to be more active in these sessions, girl, because this is going to break your ice. Ice breaking is very important, right?
Thank you so much, ma'am. Really, you changed my perspective of liverboard. Thank you so much.
Always welcome, always welcome. And that is my best course, and I really love my labor ward course so much because
No, ma'am, we were discussing with my study buddy yesterday about your course. So definitely we will avail it, inshallah.
Okay. Thank you so much. Welcome.
Thank
Take
you.
care. Keep studying, and please come out of that fear of part 3. Please, it is much simpler than part 2. The only thing, you are not supposed to listen, you are supposed to speak. So even if you are coming in free sessions, even if I give a chance to speak, okay, present this particular line, say this particular line about smoking, psychosexual counseling, do that. Do that. Okay?
Okay. Thank you, ma'am. Thank you so much.
Bye-bye. Good night.
Thank you.